Okay, I go forward. My task is to cover the prevalence of diabetes, which is facing rising challenge in the Middle East. And this is time for action. As I just, want to take you back, as you can see that Dubai 60 years ago, we have, massive changes had took place, as you can see from this picture. And of course, any change and any expansion, it is with a price. And as you are all aware, that diabetes and pre-diabetes is the outcome of our lifestyle. And as you can see from our, rows, it's packed with vehicles, which indicate that we have a sedentary lifestyle, and also our dietary habit had changed, and that had contributed to the rise in the diabetes and pre-diabetes in United Arab Emirates and also in the MENA region, as you're going to see. Now, I would like to share with you the Dubai Household Survey. We do a survey in the Emirates of Dubai every 4 years, and this was conducted in the year 2014 and 2017. And also, we did a new survey in 2019, just before the COVID hit us hard. This household survey, it is in collaboration of Dubai Health Authority and Dubai Statistics Center. It's a cross-sectional, multi-stage stratified survey. The houses were visited to obtain a detailed information of different health-related issues. There are almost 5,000 families were screened, and out of those 5,000 families, they were equally distributed between nationals and expat. As you know, we are a multinational country, so we have equal distribution in order to understand our population better. There were a good response rate of 80%, and the final sample was around 13,000, and they were about 7.9% were Emiratis. The design and the methodology of the survey was robust, and it was based on the World Bank Living Standard Measurement Survey and the WHO. So we did publish this in the Dubai Diabetes Journal. It's a journal which is owned by Dubai Health Authority, and I'm privileged to say to be the chief editor for this, and my colleague Dr. Hassanin is one of our associate editor board as well. So what we found out of this prevalence of the diabetes and pre-diabetes among the Dubai population from this household survey in 2014 and 2017, that among UAE national, we have 19% who are diabetic and 18% who are pre-diabetic. And similar to that, among the expat, we have 14% who are diabetic and 15% who are pre-diabetes. So that puts the entire Emirates of Dubai as such, that those who are diabetic in the Emirate of Dubai are 15%, and equal to that, we have 15.8% who are pre-diabetic. So you can see the magnitude of this problem. It's huge. Now, there's another publication we've done from the other survey which we conducted lately in 2019, which is the prevalence of diabetes associated with health risk factor among adults in Dubai. And what we found that the overall prevalence of diabetes in the adult age group 18 and above was 13.7%. Among UAE national, it was 19.3%. And the expat 12.4%. So that means we did not change much from the household survey of 2014-17 till date. There were slight decrease in the prevalence among the non-national, probably because Dubai is a dynamic city, so people move in and out. Now, we did correlate this prevalence of the diabetes to the age. As you are all aware, as we grow older, that the prevalence of diabetes, it increases. And as you can see, for those above the age of 60, the prevalence of diabetes is 43%. But my concern, and of course the concern of all people who work in this field, is those age group between 25 to 44, where younger age group, where we found that the prevalence is high as 8.5%. And as you're going to see later, it's also the same in the pre-diabetes. Now, take time. I know that there's some animation problem with this slide. Now, we did also correlate it in this in this survey the weight as well, and we found that those with a normal weight have a prevalence of 7%, those who are overweight 11%, and of course if they are obese the prevalence is even double. So we looked then to the physical activity of those patients, and we found that among Emiratis, if they are physically active, then the prevalence of diabetes is 10%. And if they are physically inactive, this percentage it doubled to 20%. Similar to that is among the expat. If they are physically active, then it's 8%. If they are physically not active, then 10%. So the key here is the physical activity and also the weight, as you have seen. Now, if we move on with this, and we specifically looked into the exercise itself in terms of intensity and frequency. So we found that those who do a moderate intense physical activity, and we define it as 10 minutes spent doing different type of household or even walking at work, out of those only 17% who do daily activity, 18% who do between 1 to 3 days per week, and the majority, 65%, do between 4 to 6 days per week. And just to remind you, it's just 10 minutes that we are requiring from an individual. Now, when we ask those people about the vigorous physical activity, only 5% who said we do a vigorous physical activity, which is defined again as a 10-minute, for example, running or playing a football just for 10 minutes and continuous. So they are not much. So that's another issue that we have in this part of the world. So if we look back to the prevalence of diabetes and pre-diabetes for those who's exercising is just 8%. If you are exercising, then your prevalence is 8%. If you are not exercising, it even doubled to 20.7%. Now, are we alone in this region? No, we are not. We are not alone. This is also applicable to the rest of the MENA region, as you can see, from our neighborhood country like the Gulf states, and also from rest of the MENA region. For example, Kingdom Saudi Arabia, the prevalence is around 25.4%. You look at Kuwait is 18%, Qatar 16.7%, and if you look at the other part of the world like Jordan, 23%, Pakistan 26%, and Morocco 10.6%. And that's high not only for diabetes as well as for pre-diabetes. We are not surprised to see this because, of course, we are exposed to the same environmental factor, and also we have almost the same culture and eating habit as well. So as already I mentioned, this is the map just to show you that we are from east to west in the MENA region. We have a high prevalence of diabetes across the MENA region. So our government many years ago had published the vision for UAE 2021, which was delivered last year, and the goal was to reduce the non-communicable disease mortality and prevalence of the risk factor by reducing the prevalence of diabetes in adult age 20 to 79 years of age, and also reducing the prevalence of the obesity in children among the age 5 to 17 years of age, and also reduce the prevalence of smoking among adults. And that is collectively to reduce the cardiovascular risk factor and mortality and morbidity. Because of those rising and alarming figures that we have seen in the diabetes and pre-diabetes, we already started a discussion and a dialogue with all our stakeholders in order to put a plan for prevention of our population. So, if I tell you that we can stop diabetes, of course we cannot stop diabetes once it happen, but we can stop the progression of diabetes by preventing diabetes from happening. So we need to identify this group of the pre-diabetic. So with this, I would like to take you to our last household survey, which is conducted in the Emirates of Dubai. It's almost the same methodologies that I mentioned earlier. And I look specifically now to the pre-diabetic. All that, whatever I presented, it is related to the diabetes. So for the pre-diabetes, what we found that among Emiratis, 12% of our Emirati population are pre-diabetic. and it's even higher in our expat, 17%. The overall prevalence is 16.2%. It means that among 1 in 6 individuals in the Emirates of Dubai is having prediabetes. So it's a big number. Now, we also correlated this to the weight. Those who are underweight, they have low prevalence of prediabetes. Those with a normal weight have also low prevalence of prediabetes. And of course, those who are overweight, they have a high prevalence of diabetes. As you can see, Emiratis 12.6%, expat 25%, and that make the overall prevalence of diabetes in the Emirates of Dubai 23%. So while in the obese, the prevalence is high, but of course, is, as you can see, a little bit lower than the overweight, and that's for an obvious reason, because by the time, you know, at that time when they are obese, they already develop diabetes at that stage. Okay, so we also looked in those prediabetes related to their physical activities. And as you can see here, among Emiratis, if they are physically inactive, they have double prevalence of diabetes. Similar to the expat, if they are physically inactive, they will have 2.5 times high prevalence of prediabetes. And then we also looked into the age, the same way that we looked into the diabetic. And you will be now surprised to see that also the prevalence of prediabetes is increasing with age among the Emiratis populations as well as among the expat. And again, our concern here is the age group between 30 to 39, they have a high prevalence of 11.5%. And not only those age, even the teenagers, they have a high prevalence of diabetes in this country. So, and in the line of this, the Emirates Diabetes Society had published a consensus guideline for the management of type 2 diabetes in 2020, which was endorsed by the Ministry of Health and also the Dubai Health Authority. And it was written by 22 key opinion leaders across UAE. And we recommended that the ADA screening should be adopted. That is the American Diabetes Association screening criteria to be adopted. But what we did, we lowered the age of the screening to the age of 30, not to the age of 45, which was recommended by ADA. And the reason we lower the age for the previous slide that I've shown you, because we have a high prevalence of prediabetes in this age group. The other screening is to screen any adult who are overweight or obese with one or more additional risk factor. And also, in terms of follow-up, those people with a normal test result to have their repeat testing once every 3 years, unless the condition is changed, and every 6 months if the person is diagnosed with prediabetes. And also we put some strategy. Of course, we need to identify those individuals. And once we identify them, then we will enroll them in a prevention or a structure prevention program, which include weight management, nutritional therapy, and exercise, and smoking cessation. And when it is required, then we can add the pharmacotherapy for prediabetes if lifestyle fail. So we look to simple tips that we want to tell our patient that they need to lose weight more than or equal to 5% is needed to produce a beneficial effect on their blood pressure, on their sugar control, as well as on their lipid. And also we encourage them to do an exercise more than 150 minutes per week for over more than 3 days per week, with more than 2 consecutive days without exercise. We also advise them for healthy diet and also smoking cessation. So they are very simple tips. If they follow, then we can reach the target. Now you are all aware that Dubai became very active city as well as United Arab Emirates in the past several years because we had that vision from our leaderships and also from our authorities and Ministry of Health. So Dubai had started initiative called 3030 as well as there are many walkathons which take place across and campaigns toward patient campaign and education across the year. And this is a very a good initiative that our country took towards this. But still, there are many things are still needed to be put into place in order to stop the progression of this disease. So with this, I come to my last slide. As you have already seen that the prevalence of diabetes and pre-diabetes in United Arab Emirates as well as in the MENA region is high, and the prevalence of diabetes and pre-diabetes is strongly related to the age, obesity, and physical inactivity. And I use this form of the platform to call for action for an urgent structure educational program for prevention in order to stop the progression of this disease. And with this, I would like to thank you all for your attention. Thank you.
Thank you very much. I have one question for you, Doctor. In your mind, what will be the most important factor to be implemented to reduce the prevalence of diabetes? Yes. Take your time. Are you
Sorry
okay?
about this. I have sore throat now, I don't know why. Can we do it later?
Yeah, okay, it's fine. So let's move to the dialogue between Sanofi and Servier. I'm really pleased to introduce you Niven Al-Khoury. I just changed the slide, yeah. So Niven, you're General Manager of Sanofi's General Medicine, Saudi Arabia and Gulf countries. And Anthony, I don't know if you can hear us. Anthony is with us remotely. And Anthony Mallet is General Manager of Saudi Arabia and Gulf countries at Servier. I don't know if Anthony can hear us.
Yeah, I can hear you.
Great. Perfect. Good morning. So my first question will be for you, Niven. When it comes to preventing and fighting the battle against diabetes as a public health priority, how important do you think are public-private partnership? And from a Sanofi perspective, how are you demonstrating leadership?
Thank you very much. First of all, I would like to really thank you so much for the great opportunity to represent Sanofi in a very, very valuable forum today. And thank you, Dr. Fathia, for the amazing information as well and the call to action. So when it comes to the public health priority, we strongly believe it should be a community priority, right? The governments should not really bear the burden and the weight of all of the public health on their own. And that's where, hence, the private-public collaboration and partnership is very, very important. For us in Sanofi, we totally believe in the collaboration and the impactful partnerships we call, the continuous partnerships that are very, very important to ensure a real true impact on our community. So with our experience in fighting against diabetes for over a century now, we strongly believe of our holistic approach, if you allow me, in providing a comprehensive care. So it's very important, the innovative treatments that are continuously brought to the medical community, but we also believe the importance of the education and the knowledge and the awareness. Dr. Fathia raised a lot on that, but also the digital solutions, as we're going to see. But last but not least, that brings the whole thing is the collaboration and the impactful partnerships. And that's where we can really continuously improve the lives of patients and improve the health outcomes. Among those private-public partnerships, we're very, very proud of so many initiatives, but maybe I'll focus on kids program, where it is brought into the schools because we understand that, you know, as part of the health strategies of any government, it's very important, especially in the region, is really the prevention. So how can we look at and work at the prevention and the education and raising the awareness?
Okay, thank you. And Anthony, so we started this talk with type 1 diabetes in children. Moving to type 2 diabetes in adults, can you enlighten us on Servier's initiatives in this domain?
Yes, thank you, Cecile, for the question. Good morning, everybody. Good morning, Dr. Fatia. Good morning, Niven. As it has been said, as we are speaking, today we have 6.3 million people living with type 2 diabetic within the GCC countries. Public health improvement is a responsibility of everyone, as said by Niven. This is not only the responsibility of the authorities. The pharma industry needs to work hand in hand with the local authorities to win the fight against this type 2 diabetic disease. In Servier, the patients are at the heart of all our activity. We work with the patient and we work for the patient to better co-create innovative and efficient therapeutic solutions. As an example, we have created the program Act Now for Diabetes. It has been launched as a global digital initiative. And I think you already understood that there is no, I would say, big science in this disease. The most important is the prevention, and the priority should be focused on education and awareness.
Thank you, Anthony. And thank you both of you for this introduction. And so, Niven, we've heard about the KIDS program and Sanofi's partnership with the International Diabetes Federation. And can you maybe talk a bit more about the KIDS program frameworks and the KID framework, yes, and how you have successfully implemented it in this part of the world, and how essential is it to have such programs implemented in this region?
Thank you. So the KIDS program, as you said, it's created by the International Diabetes Federation, the IDF, and the ISPAD, so the International Society for Pediatric and Adolescent Diabetes, in collaboration with Sanofi at a global level. And here it's really driven by the fundamental belief and the strong belief of the value of raising the education and the awareness, and the important, I would say, key role that nurses, teachers, and parents play, not only in the prevention of the type 2 diabetes, but also in fostering a safe environment for children who are living with type 1 diabetes. So from that perspective, that's where the KIDS program was born. And here we're very, very proud to say that that program has been rolled out in the UAE 6 years ago, so for over 6 years, in collaboration with the Ministry of Health and Prevention and the Ministry of Education, where I would really, if you allow me, to really recognize and appreciate all of their efforts, endorsement, support, and collaboration, because it comes back again to the partnership and the collaboration to make it a real impactful program, and we still see the impact. So over the last 6 years, we see we have educated over 44,000 students in 94 schools across the UAE, educating more than 3,000 teachers and more than 2,000 parents. So you can see the impact that this continues to bring, distributing and working in collaboration all together on distributing over 60,000 leaflets, booklets, all of the educational, I would say tools that can be very important in schools, but also at the parents' house and their caregivers. So as you can see, it's very, very important. We believe that, the success of kids is because it starts in the school, and that's where it's important. That's where the prevention starts, but also, again, how do we create that important, safe, and healthy environment, raising the education, as you said, on how to become active, have the right lifestyle from a very young age. And therefore, when they are out of the school, hopefully they will be also the educators and therefore the ambassadors for this, and change their habits in that. And that's why kids we're very, very proud of that, and we continue to really be proud of the impact that it is really generating generation after generation.
Thank you very much. So thanks to Niven, we now know about Sanofi's Kids program. So Anthony, can you please tell us more on Servier's Act Now for Diabetes initiative and its local implementation?
Yeah, of course. So Act Now for Diabetes is a global initiative developed with and for the type 2 diabetic patient, as I said before. It is a social media campaign where the objective is to raise public awareness and prevention about type 2 diabetic. The campaign has been launched in collaboration with the Ministry of Health and Prevention. Macum social media public platform has been coupled with a Servier GCC Facebook page. This Act Now for Diabetes focus on educating the public about three, I would say, main action or topic. Leading a healthy lifestyle, as it has been said before, so meaning diet and regular physical activity. Encouraging the public to check their blood glucose level on a regular basis, and on the importance of early detection in the prevention of type 2 diabetes and its complications.
Thank you, Anthony. Niven, I have another question for you. In a never-changing healthcare dynamic, how is Sanofi coping up with this ongoing digitization of healthcare services, especially in the area of chronic disease, such as diabetes, which has been around for quite some time?
Well, first, it's important to highlight the importance of how do we continuously engage very closely with our customers and patients to really understand the real evolution of the needs and gaps. So, as you said in the question here, today's world where we're living even more and more the digitization, right, throughout what we live in throughout the pandemic, we learn a lot, and we also see lots of changes in our customers' needs and patients' needs, where the acceptance and how the way they embrace digital solution is becoming way much higher than before the pandemic, and not only higher, but it's becoming part of the urgency and part of their needs, day-to-day needs, right? So hence we started co-creating, as we were talking about, the co-creation, and the idea came with the digital patient education program, which we will launch. We're working on it and we're launching it soon. And the idea here is very important in the palm of the patient's hands through a simple application. How do we can have a designed and personalized content to help and support that patient into reaching the lifestyle that is really tailored by that patient in particular. And of course, it's always in line and aligned with the physician's recommendation. So what does it do? It's a real comprehensive tool application that connects first better between the patient and her or his physician. So it's a better communication tool, I would say, connecting them always together, but also have that comprehensive, I would say, care coach online that is always available to support the patient as needed. So we're very, very proud. We see it as it is the first of its kind that will come into the market, and we believe that it's going to really help and support patients, but also physicians on their day-to-day management of these conditions, so that, bringing better health outcomes again to the patients and their caregivers as well. So in the palm of their hand through a simple application.
Thank you, Niven. And Anthony, as you mentioned, patients are at the heart of all Servier's activities. You've shared with us the Act Now for Diabetes Patient Education Initiative in type 2 diabetes. What can you tell us more about Servier's digital solution and patient education in the new era of digitalization? We can't hear you, Anthony.
Yeah, this is my usual mistake. I forgot to.
Okay, it's perfect. It's perfect.
Sorry about that. So what I was saying is, first of all, I do echo what has been said about the evolution of digitalization in the healthcare services. The whole medical community now use digitalization. By medical community, I mean the healthcare professional, but also the patients. Today, digital transformation is a norm in Servier. This digitalization has opened new doors for exciting opportunity and new dimension in order to educate the patient and in order to increase the awareness. Digital education platform will be soon available, and we are working on mainly My Health Partner, a website which is dedicated to the education of the type 2 diabetic patient, and very much adapted to the GCC and local situation. The primary focus is to help the patient having a healthy life and living better with their disease, type 2 diabetic disease. The second digital tools we are focusing on is an app, Diabetes World, and this app is supposed to be the daily companion of the type 2 diabetic patient. In this app, the patient will be supported in his daily life, in his prevention action, in his daily diet, in his physical activity, in the monitoring of his symptoms, complications, and much more than this. So these are the two digitalization tools we are focusing on in Servier.
Okay, thank you, Anthony. And Niven, I have a last question for you. In line with the above, what is Sanofi doing to develop solutions and services for the patients beyond the pill? How does the future look like?
Thank you. So again, with over a century in fighting against diabetes, we strongly believe in continuing to provide the continuum of care through different solutions. And again, it's important to highlight digitalization is because to simplify the way and to really respond to the unmet needs. So it's important to continuously understand the evolution of those unmet needs and those gaps so that we provide the right solution and therefore connect, as we say, physicians, healthcare systems, and patients, but even with the caregivers, as we've seen in different examples. So globally, there are so many digital solutions, let's put it this way. But what we believe is, and we work very, very closely with the different partners and various partners across the world in bringing the important solutions to the patients and to the healthcare system. So I'll just list as an example among them. We're talking about the continuous glucose monitoring system for glucose monitoring effectiveness. We talk about the smart caps for the insulin delivery and insulin dosage. We bring also the MyDose Coach titration application. Also, we look at beyond the clinical research trials and the clinical trials, the real-world evidence. So how can we bring also the digitization in speeding, bringing those valuable data? So if I give an example and I zoom on a couple of them, and I will start by the MyDose Coach application. It's a titration application. It has been launched in Saudi Arabia and Kuwait, and it's ongoing for UAE. It's the first of its kind, FDA approved, EMA approved, which helps really the patient in a very simple way and the physician so that it suggests an optimized basal insulin dosage that helps the patient to reach to the optimal dose without going higher than needed or lower dose, taking lower doses, in a very simplistic way of saying it. So really brings lots of empowerment to the patient and safety as well, to ensure that they are starting on the right dosage. Looking at the real-world evidence also, we believe that, of course, the continuous clinical research and trials is very important. But beyond that, digitalization as well has helped us to bring a real-world evidence in a very fast way, which means assessing in real-life setup important data that brings important value inputs, so that helps us as a company, as Sanofi, in partnership with the health authorities, with physicians, medical communities, to tailor and design the needed programs, the needed education, and therefore evolve based on the outcomes, the real collaboration needs. So it comes back again to better insights to drive the better collaboration or impactful collaboration.
Thank you, Niven. And Anthony, I have also a last question for you. We've seen the challenging of patients with type 2 diabetes in terms of high prevalence and low control rates. We have also seen how education, increasing awareness, and digital solution can help. What other challenges do patients with type 2 diabetes face, and what can be improved?
Definitely, I would say compliance and adherence to the therapy. These are the major challenges faced by the patient in the type 2 diabetic disease, and in any chronic disease, I would say. The compliance and adherence has a great impact on control rate and quality of life for the patient. Improving adherence go beyond the pill itself, especially in the framework of digital solution. There is a lot of options which can be used to help the patient to better comply with its treatment. In this, I would say, logic, we are developing the 2022 Ramadan campaign, a campaign which will be here to help the doctor to communicate with their patient, to sensibilize them, and to help them to properly comply with their treatment. This campaign will help them to advise on tips how to fast during the month, how to safely fast during the month of Ramadan when you are a diabetic 2 patient, while maintaining your glucose control. And this type of campaign is really supposed to be a very high level of communication tool for the doctor in order to sensibilize the patient. And as I say, not only about the disease, because here we are speaking about patients who are already diagnosed, but about the importance of complying with the treatment. Second thing we are also focusing in order to improve this adherence or compliance with the treatment is to provide real-world evidence studies which will help the doctor to have better data, better understanding about the patient, and better understanding how to improve the quality of life of the patient. So the more and better we understand the patient, their need and their expectation, the better the medical community can fight with this chronic disease.
Thank you, Anthony, and thank you both of you. So now we can move to the Q&A session. I don't know if we have questions from the chat. Yes? So...
Yes, we do.
Thank you.
Just 1 second. I will put my camera on. So we have several questions from the chat room. Hello, everyone. So it's for Dr. Fathia. And the first question is, how was the pre-diabetes status defined in her survey? Was it clinical, biological, etc.?
Sorry, can you repeat that? How was the pre-diabetes?
So how was the pre-diabetes status defined in your survey?
Yeah, this is based on the AD criteria of the of A1C. So we took the AD criteria for that.
Okay, thank you.
Which is 5.5, the A1C. Okay?
Okay, great, thank you. And the other question is about type 1 diabetes. Do you see any difference in terms of prevalence and incidence of type 1 diabetes in the United Arab Emirates compared to the rest of the world?
I can say yes, but we did not look into this in our household survey. But this is a real good question, which also had explored this discussion when we looked at our data. And I think in the future, we need also to look into this. But I can say yes, this is from the admission that we see in the hospital for those newly diagnosed or those who come in acute status like diabetic ketoacidosis.
Okay, great, thank you. And there is one last question for you. Is there any link between the insurance coverage and the progression of prediabetes in the United Arab Emirates?
I think insurance is a huge problem all over the world, so UAE will not be different than the rest of the globe. Especially the insurance system had been established in the past few years here. We still need to understand it, learn it, digest this, but yes, it is a hiccup as well, yeah.
Okay.
I hope we will overcome this over the years.
From the chat, these are the only questions. If the audience has any more questions, do not hesitate to ask them in the chat room. Thank you.
Thank you. Are there questions in the audience here physically with us or no? No? Okay. Yes?
Thank you for this. All those figures you are talking about prevention, and that's a key. That's clear. It's a key, but in particular to identify with that risk of diabetes or pre-diabetes. But I was wondering, I was questioning to which extent it is reversible. I mean, is it a short-term stake or not? If I'm a man of 40 years, overweighted, and with no physical activity, and then I change my lifestyle, will it take 1 year, 2 years, 10 years to change my risk of having diabetes? It means it could be a short-term issue or a long-term issue for a country. You are talking about education, which is long-term, that's sure. But I was wondering about the short-term impact of changing the lifestyle.
I think, can I just take, yeah. I think it's important, that's a good question, because we need the sustainability of this. It is, first of all, it is reversible. If we follow that lifestyle, it is reversible. But of course, we need sustainability for this. That's why what we look at, I know that there's a fantastic, effort is done by all our, stakeholders, including the industry, toward this. But what we really need is, a structured educational a program which can be as a prescription, the way we prescribe the medication to our patient, it should be as a prescription. And not only this, I just want to also second what my colleague had said, that it should be smart, because we live in the smart era now, because of course, with this percentage of a high prevalence of, pre-diabetes, you cannot educate the whole population face-to-face. It's impossible, especially in a busy clinics and also hospital with busy physician, with limited number of, educators. It's impossible. So I think the smart application will be good, but we need to think of, a robust smart application that can be adopted with supervision of, for example, of coaches for the patients and a continuous follow-up. Okay.
Thank you very much. And Anthony, Niven, if you want to react or to ask questions to each other, you can. Just tell me. Dr. Fateh, I just want to ask you my question.
Sure.
So in your mind, what will be the most important factor to be implemented to reduce the prevalence of diabetes?
I can say the physical activity, as I already shown you, because I think, to change people of eating habit It is not possible. Because, you know, especially in our nation, in this part of the world, we love food, you know, and we like to indulge in parties and all. And we have now many also, you know, cafes, restaurants, and the first thing that even when we travel, the first thing we'll ask, please send me the list of the best cafe and best, you know, restaurant in that country. So I think to change people eating habit is impossible. So I think the only thing that if we work on is the physical activity. I think that's win-win situation. But of course, we will be requiring you know, many places to do this, because now we do have, for example, in UAE, many places which, you know, provide this. But as you know, that when you go to gym or clubs, it's expensive and it's not affordable for many people. Sometimes, you know, it's quite high. So if we provide them with other tools, as I mentioned, you know, like the smart application, then that will be another easy. With, you know, even if you're going to charge them, let us say, even if you put this on the bill of the insurance and you charge them for a minimum fee, I think that will be more efficient.
Okay, thank you. And you're talking a lot about the importance of lifestyle, but I'm wondering, are there genetic reasons to explain why diabetes in this region is so high, or is it just lifestyle factor?
I think our genetic did not change over the past 60 years. We are having the same gene. But I think it's our environmental factor which had changed. So if anything we have to do, we have to play around our environmental factor.
Okay, thank you. It's very clear. Okay, do we have question? No, okay. So thank you very, very much. It was really interesting, and we were very honored to have the three of you here today. And so now we can move to the pitch session. So first, to make the link, with the previous session, I would like to introduce you Eric Deserten, CEO of Biocorp, because Biocorp, if I'm not wrong, has signed 2 years ago a contract with Sanofi for its digital innovation. So Eric, can you hear us?
Yes, perfectly. I hear you.
Okay, so I leave you the floor.
Good. Thank you very much, Aziz. Thank you, everyone. Very happy to be with you this morning, even if it's virtually. I'm the CEO at Biocorp. So we are a French company active in the field of digital health and medical devices. And for the last couple of years, we've been working a lot on diabetes and providing a solution for patients that are treated by insulin and more precisely by pen injection. So this morning I'm here to talk about Biocorp, but I'm also here to share a story, and that's the story of Sofia. So Sofia is not my wife, she's not my sister, she's still a friend. We know each other for a pretty long time. She's working as a software engineer in a biomedical company, and she's very athletic. We've been running a marathon in Paris in 2014. But Sofia is not exactly as the same as I am, because I'm not diabetic. She's diabetic. She's type 1 diabetic. She's been diagnosed at 8 years old, and she's living with that disease since then. So as you know, diabetes is, I would say, is a pretty complex disease, as we have to monitor the blood glucose level of the patient a couple of times per day and making decisions a couple of times per day, which is, I believe, something completely unique in that way. I don't have any other disease in mind where there's so much complexity in managing your treatments upon different type of criteria, so physical activity, stress, etc. So Sofia is living pretty well his life, but sometimes, like any other patient on that planet who is managing diabetes and insulin, she's forgetting about her treatment. She's sometimes worried or anxious about making another shot of insulin because she forgot what she did 5 minutes ago. So that's big issue, and that's big, I would say, complexity is related to adherence. Adherence is approximately impacting 50% of chronic patients over the world, and it's also impacting diabetic patients. So at Biocorp, we try to develop some tools to help patients, and more precisely here, insulin-trained patients to better live their life. So it's really in that context of providing serenity, of providing simplicity, that we have developed our solution. So our solution, and I will give you more details later on, is that a small sensor that attached to existing pen injector. So the pen injector is being used by approximately 60 million patients on that planet on a daily basis to administer basal insulin or rapid-acting insulin. So we are together with some partners, blood glucose monitoring companies such as Roche, or insulin companies such as Sanofi, as we mentioned before. We are partnering together and provide what we believe will be a comprehensive solution for the patient ultimately. Our goal is to help the patient better manage his disease, improve his clinical factor and evidence, so working on the A1C of the patient, and provide him a life like any other person on that planet. That's really the ambition of Biocorp. So in a nutshell, our product, Malia. So it's a simple way on purpose. As you understood, the life of diabetic patient is already pretty complicated, so we want to
Thank you very much, Eric. We will keep the question after the three pitches. Thank you.
Sounds good. Thank you very much.
So now let me introduce you Frédéric Dayan, CEO of ExactCure, and you will present your digital twin technology allowing better management of medication intake. I leave you the floor.
Okay, do you have the control of the slide?
You can. Yeah, just
thank you.
2 seconds.
Well, before the slides, first of all, it's a real pleasure to be here with you today at this fantastic expo. It's a pleasure also to talk about my company, the company I created 4 years ago, ExactCure. Well, you will see it in a few seconds, I hope. Yeah, that's technology, but we'll talk about technology too. It's a bit different from diabetes. You will see that. Well, diabetes is one of our fields of interest, but not the only ones. Well, we are applying artificial intelligence and modeling, what we call digital twin, to the drug modeling, and in particular drugs in diabetes, but not only. I think I have the control.
I think it's okay. Yeah.
Yes, it is. So we're going to see how artificial intelligence could help to personalize medications in general and to properly use drugs. We are a medical device, we are a digital medical device. But first of all, the starting point is maybe why? Why ExactCure? You know, it's a startup, so why are we so motivated every day when we wake up at ExactCure? Well, it's because we think that drugs are maybe one of the best inventions in the world. That's true. It's almost magic if you think about that. You're sick, you take a pill, and you're not sick anymore. But we also think that it should only do good to people. And as you know, it's not the case, not all the time. There are more people dying because of inappropriate medications in the world than in road accidents. 5 times more. For you and for me, it's not acceptable. So we have to fight against that. And of course, it costs a lot to insurance companies, to pharma companies, when you know the cost of a drug. So how to avoid those underdoses, overdoses, or drug-drug interactions? Well, why is it so complicated? Actually, it's because we all react to drugs in a different way. That's the principle of personalized medicine. So what we propose is what we call our digital twin. This is a digital medical device that is integrating your own characteristics, your age, your weight, your height, your pathologies, etc. And then what you see here is the patient version. We have a patient and the healthcare professional version. This is the patient version of the medical device. This is a very simple dial, a clock, and when this patient takes a pill, this is an example of a painkiller, a new ibuprofen, for example. If he takes an ibuprofen at 6 p.m., we say, okay, it's not active just right now. Wait, it will be active in 20 minutes until tonight at 11 p.m. approximately. And you see this green strip around the dial. This is a reflect of the drug intensity as a function of time at 6, 7, 8, 9 p.m. And if you see it closely, you see it's not homogeneous. The intensity of the green is dependent of the intensity of the drug. This is PK/PD for the one who are doing for my pharmacology. Well, I'm a former pharmacology teacher, that's why. But that's a good scenario. But let's imagine that now that there is a problem. This guy is taking too much of this drug. 400 milligrams is too much because, for example, this guy has a kidney or liver issue. Then we simulate that as a function of time. You will see between 7 p.m. and 9 p.m. that the intensity is red. It's too much. This guy will be overexposed to the drug. So this is the core service that we provide. We are unique. We are the only ones to provide this type of on-demand service, on-demand simulation, personalized simulation of a drug. And on top of that, we provide also a pill reminder for compliance, for example, and a lot of other things like real-world evidence collection, how patients take drugs, how do they feel when they take their drugs. I can make you a demo if you want later. It was the patient version. This is the healthcare professional version. I took an example in the field of diabetes, one of the most famous drugs, metformin. And you see for this woman, because she's 55, she has a strong renal impairment, then this classical drug regimen is too much for her. This is a bit more detailed for healthcare professionals. This is not a dial, this is a curve, the pharmacological curve as a function of time. You see, in green and red, this is the therapeutic window. This drug goes above the overexposure threshold every day for this woman. So this drug regimen is not appropriate. So if you adjust the drug regimen, for example, 500 milligrams for this woman 3 times a day, you see that then she stays in the therapeutic window. Okay, as a conclusion, I would say that we bring 3 innovations to the world. First of all, this is a disruptive usage because, well, now when we take a drug, we're kind of blind, in fact. It's like driving a car without any dashboard, without any speedometer. We provide a drugometer, if you want. So, second, this is in the scientific approach, how we provide our simulations. This is what we call meta-modeling. Our artificial intelligence is screening the literature, the clinical and scientific literature, and is analyzing all the influencers of a given drug, weight, age, height, and so on. And then we integrate all those factors in what we call a meta-model of the patient, and this is what we provide in the application. We'd be glad to enter into details, trust me. And third, we also integrate the patient feedback to improve our understanding of the drug and to collect real-world evidence and to improve the models. Okay, we won many prizes, awards, we were invited by the MIT and so on. Well, okay, good. I would say that we are ambitious, yes. We want to become a worldwide reference in personalized medication simulations, and we are very proud of what we do. And we want to collaborate with hospitals, with pharmaceutical companies, because we believe that in a couple of years, exact cure will be obvious, and that we won't be blind anymore when we take our drugs. So this great, a fantastic invention of mankind. So thank you.
Thank you very much, Frédéric. And now we are moving to Arnaud Lambert pitch. Arnaud Lambert is CEO of AI Screening, and he will present his AI diagnostic aid algorithm, and in particular its application in the screening of diabetic retinopathy. Arnaud, can you hear us?
Absolutely. Thank you. Thank you, everyone, for having us this morning. Hopefully it's way hotter in Dubai than it is in Paris, with a little over 0 degrees here. Let me get into the presentation this morning. I really am very much like the intervention of Dr. Fathia, Niven, and Anthony, and it echoes pretty much the work we've tried to do over the past years with AI screenings. So what we do, we are a company that was founded 4 years ago. We are a medtech company. We are ISO 13485 certified by the BSI, and we basically do artificial intelligence medical devices, and we work in the field of ophthalmology and dermatology. The first medical device that we developed is for diabetic retinopathy screening, and the reason why we did it is actually to echo what has been said this morning. 1 out of 3 diabetic patients will have diabetic retinopathy. So it's not so much a question of if the diabetic patient will have the pathology, it's more about when will the patient have it. And when we actually focus on type 1 diabetic patients, the literature shows that 9% of those patients will develop at time diabetic retinopathy. So really the challenge for us is to provide a simple tool to enable diabetic retinopathy screening, since the literature and the ADA recommendation requires an annual retinal screening. Unfortunately, there is not any more patient specialists to do those screenings, and in some areas in France and Europe and other areas of the world, you can wait over 6 months, and sometimes you don't even have a special. And with this, I'd like to end our presentation with the international recognition by Microsoft from John Doyle, who's the CTO of Microsoft Health and Life Science, because we believe that artificial intelligence medical devices should be robust, but also make sure that the data that is used upon to provide diagnosis is confidential. And we are currently working with the UCSF, which is the University of California in San Francisco, to provide that service in diabetic retinopathy. And to actually give some context, we are currently working with other countries in the region, and we are looking forward within this Dubai exposition to actually move forward and deploy our solution across the GCC region. What we have found, and this is my last take for the call for action for the ones who are in the room, we have found in certain underserved areas that we are covering that the ophthalmology team is currently below the required numbers to grade the diabetic retinopathy screening in some areas of Africa. And we would like to call this action for a team of ophthalmologists or vision specialists to provide remote gradings. So if you feel up to giving some time to the community, do please come and visit us. Thank you very much for everyone and your attention.
Thank you, Arnaud. Do we have question for Eric, Frederic, or Arnaud? And maybe from the chat? No? Okay.
From the chat, there is still one question for Dr. Fathia, if she can still answer it. She seems to be the popular one today. So one last question for Dr. Fathia.
Yes, please.
From your point of view, what could be the criteria of reimbursement for advanced technology in patients living with diabetes?
Difficult question.
Yes.
Very difficult question. I don't have answer for it right now.
Okay.
Yeah.
Okay.
Well, anyway, the questions were quite interesting, so thank you for asking them. And so far, we don't have any more questions from the chat, if someone else has.
Okay, I have question for Eric, Frederic, and Arnaud. So we will see if after that we will have a question from the chat. First, Eric, I don't know if you can hear us again.
Yes, I'm hearing you.
Yeah, so thank you for your presentation. I have a few questions for you. First, in which way Malia is changing the life of diabetic patients?
It's a good question. So as you understood, diabetes management is pretty complicated. Insulin management is very complicated. So insulin is something that happens for all type 1 diabetic patient and for certain type 2 diabetic patient, and providing the information about insulin intake is something which is very important for two reasons. One is really improving what we mentioned before is working on serenity and lifestyle of the patient, so making sure he's not anxious, is not worried about forgetting his shot of insulin or making 2 shots of insulin, etc., which is a pretty, a very efficient drug, but also could be potentially dangerous. And the second one is integrating that information into a global digital solution that is not only about insulin intake, but has other information that related to blood glucose information, physical activities, and I think that's one of the future of diabetes management. So providing all these digital solution in a comprehensive way. I can say that it's a challenge because the industry as a whole needs to partner to initiate those solutions and then commercialize those solutions. but we hope to bring our let's say our expertise in the medical device area to help patients ultimately.
Okay, thank you. And are you the first one on the market with this kind of technology?
Yes, we are the first one. It's a project we've been kicking off approximately 6 years ago. So it could be considered as a long time ago. In reality, in the medical device industry, it's not so old. And yes, we've been investing in that technology. It's really designed at Biocorp. We are manufacturing that device as well in France. And this product has been distributed already in a couple of countries. So for us, the challenge is continuing to expand in additional geographies, and at the same time continuing to improve that product and the patient experience. So that's one of our major commitments at Biocorp.
Okay, thank you. And my last question, can that insulin intake information be connected with the blood glucose level of the patient?
Yes, definitely. That's the ultimate goal. So we won't help the patient alone. As I mentioned before, it's really a team that we need to build around that insulin dose intake information. So I think there's definitely a lot of parties around, and I've been mentioning already our partners in that area. So insulin companies and blood glucose companies that are very, very important partners and players for us to provide ultimately the best solution to patients.
Okay, thank you. Thank you very much, Eric. And
there is one last question from the chat room.
Yes, you. Okay.
So where is your smart cup available?
So it's changing depending the countries. So we've been launching in Taiwan, for instance, and it's been available in hospital and clinics. So it's under prescription from physician, and it's been delivered at hospital care. In France, in another countries where we've been launching, we are promoted in pharmacies by Roche Diabetes Care. So it's direct access to pharmacies. So I think that's a very good question in the sense that there's a model to be built around distribution of that product and new services. So I think there's no one model fits all for all different countries. But that's a couple of examples of where you can find Amalia and potentially in other countries, either us or partners could set up some digital way of getting the device, such as websites and smartphone applications. So it's pretty open in that regard.
Okay, we have a problem with the screen, but it don't mind. We don't have slide anymore. Okay, great. You're back.
Okay.
Do we have? Thank you very much, Eric. Do we have other questions from the chat? Not for now?
No, so far no.
So I have some question for you, Frédéric. What level of precision can you achieve with your modeling approach compared to what is done in research laboratories?
When we are presenting what we do in scientific congresses, we are benchmarking what is existing in terms of modeling, of pharmacological modeling. And what's interesting is that we don't need new patients to build a model. We are using the existing publications and the existing clinical trials, and we are combining them. So when we compare individual trials and the models that are the results of those individual trials compared to the integration of 4 or 5 different trials thanks to artificial intelligence, we prove that we are systematically better in terms of precision of the modeling and the simulation itself.
Okay, thank you. And do you simulate all the drugs, and how do you choose which drugs to simulate?
Yet we don't simulate all the drugs now. Our ambition is to simulate 10,000 drugs, which is quite exhaustive of the molecules in let's say in the classical country. But we are covering 3,000 drugs right now, and those drugs depend on the therapeutic domains. We have different therapeutic domains of interest, like painkillers, anti-inflammatory drugs, chronic disease in general, oncology, cardiology. But in fact, it depends on the partnerships we are making. For example, we are launching an app this month with a laboratory in France dedicated to the drugs of the family, I would say. Not the chronic disease, but the acute drugs that you buy at your pharmacy store, for example. And so we develop drug models for them. So it depends on the partnerships we are signing.
Okay, thank you. And last question, is your solution a paid solution? Who are your current customer?
For the moment, it's free for patients and free for healthcare professionals. And our business model is to deal with private companies, insurance companies, and pharmaceutical companies. In fact, if you have one drug of interest, you want to integrate in a model that we deal together, and we can sell either an application itself or the access to simulations. For example, with this lab I was mentioning before, what they are buying to us is just the simulation, the core simulation, and they integrate it in an independent application.
Okay, thank you. So okay, there is a question here. I don't know if we can have Mike, yes. I think it's coming. Someone is coming, it's okay. Thank you, sorry.
Thank you. So Frederick, really a nice presentation, and pharmacology is actually one of my really big interests since college. So I'm wondering, like, how do you? So you showed like one pill that is being there on the application for the patient. How do you combine like different pills? Are they like combined? If I mean usually. And if you consider like, older patients, they're usually having their therapy like up to 10 different medications. Yeah. How do you combine?
Yes, of course. When you take different drugs, of course you have, for the patient, you have different dials, one for each drug, in fact. So you switch from one drug to another one. And to give an example, we are collaborating with a US company right now on drug-drug interactions. And what we are working on for them is typically a case of 15 drugs in one prescription, and to integrate the quantitative influence of drug-drug interactions. So not only to switch from one drug to another one, but also to integrate the impact of drug A on drug B on this simulation.
Yeah, definitely. I mean, from that perspective, does the patient, how is that delivered to the patient? Because usually they don't have the education, right? The ones that we have maybe from the scientific perspective. So what actually does, I mean, just wanted to figure out like how patients does perceive that.
Well, I like
if they have like different, comorbidities, yes. Different like kind of.
Yes, I like to say that it's not simple to do something simple, clearly. And the technology that we develop is not simple, but we want to make it simple when you use the app, and this is what we tested with many patients. And I will show you the application if you want. You will see it is actually very simple. Don't have the feeling that you have technology beyond what you see, but. We tested with patients, and for example, we saw that it works. After 3 months, for example, more than 2/3, 66% of the patients are still using the app after 3 months, which is not bad, at least once a week. So it means that they understand the thing, and there is a kind of adherence to the application. Compared to classical application without simulation, we collect their feedback, how they feel. But not only we provide information, we say your drug is efficient or not efficient or overdosed. So I think this is an incentive for them to use the app and to make kind of effort to understand how to enter their data, which is not simple, in fact. But they make the effort because the reward is that this digital twin is the reflect of the drug they take every day. So I think there is a kind of anxiety about how the drug works, and we show them. So that's, I think, a motivation to go beyond the relative complexity of using an application like that.
Okay, so the last question, thank you for that, is for HCPs, for instance, like how do you connect different specialties? So if I'm an endocrinologist, I want to prescribe metformin, right? But at the same time, maybe this patient is also using some other medications that are not good for his current, like, therapy, maybe that will be prescribed. So how do you connect the different specialties between it?
Well, first of all, there is just one account that is put in mirror between the patient and all the healthcare professionals, the physicians, but also the pharmacists. So different specialists, for example, they can share the same patient, and then they see which specialist prescribed which drug in the history of the patient from the healthcare professional perspective. But of course, the ideal context is that every specialist uses the app. If one specialist is not connected at all, they are using papers to write prescriptions, of course, we will not be able to collect the prescription. But the ideal context, and in many countries it is the case, is a digitization of the prescription, of course. And then we are collecting the prescription, and we can share it. And that's true that this is exactly the example of the 15 lines in one prescription we are studying, because there is a cardiologist, a GP, a specialist in endocrinology, for example, and they all prescribe different drugs that are independently studied, and all the clinical trials are good for these individual drugs, but when you combine them, then of course there is a stake of compatibility and drug interaction. So yes, they share the same patient file, and we integrate DDI, drug interactions.
Thank you. Yes, we have another question.
Thank you very much, Frederick. In my last hospital in UK, we did a randomized control trial on hypertension patients, giving them education and blood pressure monitoring. The key for the education was for them to understand their therapy. What is this drug? What does it do? How does it function? What are the side effects, so that they can understand it and they adhere better to therapy. And the outcome for the study was those who received the education got better blood pressure control with less pills. How can your application change the patient to be the owner of the information and to be better educated, so that if I was to go into a Dubai doctor in the private sector out of DHA with a different application, I still have the information, and I can then, I am the patient, I'm the owner of the information, and I will understand better the different drugs and why I've been taking them, and the interaction for other things. So your discussion about disease therapy, so hypertension or diabetes, something like this, how can the application help with better adherence and better education?
Yes, that's very interesting. I totally 100%, 200%, if it's possible, agree with what you say. I think that understanding is the key for patient compliance and empowerment for their drugs. We believe that we are contributing to that because we are giving something unique. This, what we call this drugometer, is a clear message. It seems like magic, like what I was saying. You take a pill and you're supposed to be cured. But it's not magic, this is science. And we show you this science in a very simple way. And the very simple notification that we send to the patient saying, not only take your pill in 10 minutes, but saying, now your drug, your metformin, for example, has reached the efficacy level in your blood. This is, I think, a message making them understand that they're not taking something magic, they're taking something that you can monitor directly in their blood. I hope it contributes to education, and I totally agree with you. I hope so, clearly. This is what we see with patients.
Thank you. We're running late, but I would like to ask two questions to Arnaud. Arnaud, can you hear me?
Absolutely, Celine.
Thank you. So my first question is, how long does it take to implement a solution like yours?
So in our experience, it takes a couple of months to demonstrate the efficacy of our software as a solution. Basically, the whole solution is hosted within the country. And for instance, if we take example of Dubai, there is a data center where we could actually host the system and deliver the service. For instance, at the Dubai hospital, within a couple of months, implementing in production. So it's really fast and easy for the hospitals or the governments to implement our solution.
Thank you. And where is the medical data hosted, actually?
Well, from a hosting perspective, we recognize it's very important that the data doesn't leave the region or the in depending on the regulation. So what we require is to have data hosting service within the country or the region that is compliant with the local regulation. We are currently in the European region GDPR compliant, and in the US compliant with the US regulation. And we understand that in Dubai there is also data centers, namely Azure Data Center, where we can provide our services from.
Okay, thank you very much. So I had to conclude. So thank you very much, all of you, for your very interesting intervention, and have a good day.
Thank you very much.
Thank you, everyone.
Allô, monsieur Zogby, vous m'entendez? Bonjour. Eh bien, écoutez, moi je vous entends également. C'est superbe. Je vous vois aussi. Est-ce que vous avez une présentation avec des vidéos et du son sur vos présentations? Oui, je vous entends. Vous m'entendez aussi? Très bien. Je voulais vous
Good morning. It is 9 o'clock in the morning here in Paris, so good morning for all. I thank the organizers for giving me the opportunity to talk about the Maryland Long Hospital and the congenital cardiac surgery department. The Maryland Long Hospital has a long historical history, as the first pediatric open heart surgery in Europe was done there in 1955. In 1988, the first neonatal heart transplantation, and 2 years ago, we passed the 2,500 arterial switch operation in a neonate. Three basic pillars of the departments are the medical pillar with the patient care, medical and surgical patient care, the training, the doctor's training and the paramedical team's training, and there's a research department for innovation, clinical experimentals. The department is composed of three separate parts: 14 rooms for neonates, 14 rooms for infants, and a service for adult congenital patients. We have an ICU unit of 16 rooms. The team is composed of 4 surgeons, 3 cardiologist interventionalists, 6 cardiologists with 2 rhythmologists, and the cardiac and ICU team is made of 6 anesthesiologists and 6 ICU doctors. As you see, the nurses are very nice. The surgical team is composed by 4 surgeons: Emre Veli, Joy Zolby, Régine Roussin, and Bastien Provost. We have 2 dedicated operative rooms, and we do, in average, 4 cases each day. What about the surgeries? In 2019, just before the COVID problems, we did in a year 951 surgical procedures. There was 129 neonates, 300 between 1 month and 1 year, 400 patients under 18 years, and 122 adult patients. So we begin with the neonatal procedures. All kinds of surgery is done, including the arch repair, the transposition of the great arteries, all the shunt closures, and the neuroventricular procedures. Here we see the operation of a transposition of the great arteries in a small little boy. It is problematic in this case because it's what we call the type C operation. The type C is when, instead of having 2 separate coronaries in each sinus, there's 2 coronaries in only 1 sinus. And the mortality is very high in such kind of patients. So here we see that we have to harvest the 2 coronary arteries together. We detach the commissure because we have to separate the 2 coronaries, and the commissure is just in the passage. So here we see how we harvest the two coronaries together. The left coronary artery is here, and it emerges here. So all of this is the left coronary artery. So here we have to finish the harvesting. But we have two coronary arteries together. Just to say, all of the cases are done in normothermia, with normothermia and blood wall cardioplegia. We don't do hypothermia anymore since 10 years. So here the intramural course is open. All of this is a common wall between the coronary artery and the aorta. Then we have to separate the two coronaries so we can put them on the new aorta. This kind of operations is a little bit risky, but since we have done more than 2,500 arterial switch operation, which is the biggest series in the world, so now we know how to manage these operations. And now we liberate the coronary arteries and the rest is done. Here there's another operation which is rare, and it's the only emergency really now in pediatric cardiac surgery, in neonatal cardiac surgery, is the total anomalous pulmonary vein drainage, which the pulmonary veins are not connected to the left atrium. It's an emergency which has to be operated as soon as the diagnosis is done, and it's usually after a few hours of life. So here it's an infracardiac drainage. It's the only operation that we still do with circulatory arrest and hypothermia. So we cool the patient till 18 degrees. We stop the heart. We take off all the blood from the body so we can operate without problem. Or if the pulmonary veins, we will see better once we stop the heart. So here we empty the heart, we take off the cannulas, we do the circulatory arrest. We open the left atrium. We see the pulmonary veins are here, the left, the right. So we have to open the pulmonary veins so we can connect them with the left atrium as in normal hearts. We mustn't go on the pulmonary vein, but we have to stay on the common. And then we put the pulmonary veins in the left atrium. It's also a very risky operation with a post-operative course depending on the size of the pulmonary veins. The repair in infants and children, we perform all the operative cases in this kind of patients. And especially we do, as much as we can, we do repair in these patients, even in small weight children. So if we have an AV canal at 1 month of age, we do the repair. VSDs even less than 1 month, we do the repair, and we do not do a banding, for example, for doing this in 2 times. So here we see a double aortic right ventricle with a restrictive VSD. See here, yeah. It's the wrong, they put the one with automatic slide. So as we see here, the VSD is a little bit small, the aorta is here, the left ventricle is here. So the blood must go from the left ventricle to the aorta. The passage is narrow, so we have to enlarge the passage here by incising the septum interiorly. And here we see the patient repaired with the patch enlargement and the flow from the left ventricle to the aorta. Here another case of a patient with multiple VSD. So in the cath lab, we closed the muscular VSD. And here we see the VSD, apical VSD muscular closed by the device, and the repair is done as the other one by enlarging the VSD and doing the passage from the left ventricle to the aorta. It's a combined procedure with the interventionist cardiologist. Here's a case of a young boy of 3 years who came from Algeria 3 months ago with this huge aneurysm of the ascending aorta. See it back, it's a little bit. Sorry, I didn't do the right. So here, there's the ascending aorta aneurysm. We see the heart here, very small. This patient was done without circulatory arrest by injecting blood in the carotids. And here is the repair after, the CT scan after the repair with a nice ascending aorta.
Your stitch was right in it.
In the case of mitral plasty, we always do repair in valvular problems, especially in mitral problems in children.
And neuroplasty, correct?
Usually we almost never put a valve, mechanic valve. So here, it's a 6-month-old child, and we see the result of the repair when testing the mitral valve. Here another, it's a AV canal. Operated AV canal with the valves, insufficiency of the valves, and here we see after the repair the results. In such cases, it's very difficult to repair for the second time the mitral valve in an AV canal already operated. This case is the abnormal courses of coronary arteries. We see the left coronary artery here, the right coronary artery rising from here and going straight. Usually the right coronary artery rises from here. This kind of problems we are encountered in small adolescents. The sudden death when doing sport is due usually to this kind of problems. So our strategy is to operate each time that we discover this, and with this special anatomy. So the operation is very easy. We just open, we do an unroofing of the coronary arteries, and the ostia now of the right coronary artery is arising from the right sinus. In adult congenital patients, all the operations are performed. Usually it's radiosurgeries because almost all of the patients are operated when they are young, and then they have to be reoperated. In this case, we see valvular aortic insufficiency. We always do, as I said, valvular plasty with of the ascending aorta and with an annulus plasty, in this case under the coronary arteries. We try to avoid each time that we can replacement of the aortic valve, especially in young patients. But sometimes we cannot do a plasty because the valves are operated many times, and our strategy is to do the Ross operation. The Ross operation is the fact of taking the pulmonary valve, harvesting it, putting it instead of the aortic valve, and then to replace the pulmonary valve by hematograft. And when we do this in tall patients and big patients, we always do what we call including the pulmonary valve in a Dacron tube to avoid dilation of the aorta, neo-aorta. So here it's what we call inclusive Ross operation. And here we see after implanting the right coronary arteries in the ascending aorta. That avoids the patient to be reoperated for dilations of the aortic root. In this patient, it's a patient operated for tetralogy of Fallot. And after operation, we see a dilation of the ascending aorta. Here we see on the operative room, operative view, the pulmonary cusps and the ascending aorta is dilated with an aneurysm. The aneurysm is resected, and the operation is done by respecting the aortic valve, and we do what we call a Tyrone David operation. Another adult cardiac operations, difficult operations, are the anomalies of the tricuspid valve. In this case, we have the Epstein anomaly, which is a rare anomaly, and our strategy is to do what we call the cone procedure, which is a plasty, a valve-sparing operation. We don't have to replace the pulmonary valve. This operation has been described about 10 years ago, and we have done our 25th case last week. So here's the case. We do a plasty rotating the tricuspid valve, and the test, water test, showed the nice results. Other operations which are frequent in adult patients are the operations on the pulmonary route. All the patients operated for these operations as tetralogy of Fallot, truncus, double aortic right ventricle, or Ross operations we have seen need to put a nomograft or a tube on the right ventricle to connecting the right ventricle to the pulmonary artery. So in this case, and as the children grow, we have to change all these devices, and it can be done safely or by operation or by intervention. Because our interventionist team do about 50 cases a year on pulmonary route tubes. Another surgery is the cardiac insufficiency surgery by implantation of the Berlin heart in waiting for heart transplantation. The last patient stayed 1 year on Berlin heart before he could have his new heart. So we are developing this kind of surgery in situ. Our collaborations, we collaborate with all the nearby hospitals and in situ services. We have another cardiac surgery team who does also all kinds of heart assist and transplantations, a thoracic and vascular team, and we did this year our first pulmonary transplantations in 4 years child. Nearby hospital, there's a Beckler Hospital and Kremlin-Bicêtre hospitals, and these centers do all neonatal and children surgery, and as well as liver transplantations. So we take care of the patients in a multidisciplinary way. Our results for the 2 last years, we see in 2020, because of the COVID, we've done a little less cases because the abroad patients couldn't come to France, and we hope that soon things will change with this disease. So we did 951 cases in 2019 and 888 in 2020, and we see the results, the hospital stay, and the good results with a very low index of mortality. I think in average the mortality in all services is around 4%. This is the global mortality with all patients, not only the surgical patients. As I said, we have a team of interventionists, of 3 interventionists. They do more than 800 procedures a year, and with 120 ASD closure a year, 50 pulmonary valve implantation, and since 2 years, a new procedure has been developed to treat the sinus venous ASD by putting a stent. It's we have in the experimental lab, we do the simulation and we see which kind of patients can do this kind of intervention. in 2024, we will be in a new hospital, and our director, Monsieur Lajonchère, will be in charge of making this happen. And here we finish with a nice slide that I love to put, and we see that there's many ways to pass through obstacles, and the oldest of us they have to show the way for the youngest on how we can do it the most easily. And here we see that many things can be done to solve the problem. Thank you for listening.
Good morning, everyone. It is really an honor and immense pleasure to participate to this Dubai Expo, although we are very much sad not to be physically present with you. Before Stéphane Comment will give the presentation of our goals, I just would like to say a few words. So we are a French institute which is dedicated to fight cardiovascular and metabolic disease, diabetes, obesity, cardiac heart failure, hypertension, which are in France, in Europe, but also in the Emirates, a major health problem. Our mission is to develop translational research from bench to bedside. And today, what we believe is that we need to change the scale of research by integrating more and more data coming from patient cohort, by developing new algorithms using artificial intelligence to develop new tools for a personalized medicine. And we have very interesting and fruitful discussion with our colleague from the Emirates. And we know that we share all this view that we need to work all together to really develop this new research and this new program for personalized medicine against cardiovascular disease. So Stéphane Comment will develop more in details what we are doing and how we view this potential collaboration with our colleague from the Emirates. Stéphane, if you want to take the lead.
Yes, thank you, Stéphane. So, as you all know, cardiovascular diseases are the first cause of mortality and an aggravating factor for COVID-19 pandemic. Given the increasing prevalence of metabolic conditions such as diabetes, obesity, and liver disease, this situation will remain a public health challenge of world magnitude. These frequent chronic diseases progress silently throughout the whole life, starting from predisposing factors, which are on the left, such as genetic and environment, with lifestyle, for example, and they will develop into comorbidities, such as hypertension, obesity, dyslipidemia, and diabetes. And at some point in life, it will induce an acute decompensation through events such as stroke, myocardial infarction, or aortic dissection that will require hospitalization. It is clear now that this disease results from crosstalk between the cardiovascular system, which is represented through the heart, and metabolic organs such as liver, adipose tissue, fat, and the intestine, with the contribution of the intestinal microbiota leading to different metabolic, inflammatory, and endocrine status. What I have just introduced is schematized in this slide, and we will see how can we move from risk stratification to personalized medicine. So on the left, you have the genetic determinants and exposure to environmental factor that will determine your cardiovascular and metabolic risk, ranging from no risk to extreme phenotype that you can find in some rare disease. Then you will have the development of different metabolic, inflammatory, and endocrine status on the organs such as the heart and the liver. That will lead into the building up of comorbidities. That will again lead to the remodeling, the pathological remodeling of organs such as liver and heart that will lead to atherosclerosis, cirrhosis, atrial fibrillation, or heart failure. When you go into the hospital, this is how you are usually end up with the risk stratification. So you have biochemistry, patient find, genomics, you have continuous monitoring, histology, multimodality imaging that will all end up for the care phenotyping. And this is all led up through the cardiovascular and metabolic risk factors. And what we are doing with research, we can deeply phenotype all these components, such as exposure to environmental factor can be tackled through the use of metabolomic, lipidomic, and metagenomic for microbiota. For the genetic determinants, we can go into genomics, epigenomics, transcriptomics to have more detail. And at the level of imaging and histology that are done in the hospital, you can go further, deeper in image analysis through labelization and annotation. And if you combine this with digital twin, with data integration through deep learning, we will be able to individualize the risk prediction, for leading from risk stratification to personalized medicine in cardiometabolic diseases. Now we will see how we can bridge together basic and medical research to create an innovative healthcare industrial ecosystem through the use of university hospital institutes such as ICAN. So this is how healthcare innovation ecosystem is built up in France. So you have the academic scientific world with university and research institute. Then you have the health medical world with hospital and medical research. And on top of that, you have the economic industrial world. And they all do research in silos. And the University Hospital Institute have been created to bridge all these worlds together to be able to develop faster innovation from bench to bedside, as we call it. So in France, we have 6 university hospitals which are combining basic and clinical research expertise on major health issues to fasten the transition of innovation from bed to bedside. And our institute is dealing with the cardiometabolic diseases, but you have other institutes that have been created that can deal with rare disease, with brain disease, with infectious disease, with other cardiac disease, with eye diseases, or with surgery. And our institute is a one-stop shop for healthcare-related industrial innovation that is built upon 4 pillars that I will detail in a minute. So we have a scientific community, we have technological platform, clinical cohorts, and a number of structuring projects that we are able to integrate with industrial partner and other academic collaboration to be able to break down barriers and to have scientific excellence, to implement those projects by project management, to tackle all legal and regulatory aspects and intellectual property and business development. We combine this with multi-omics and state-of-the-art imaging with the use of enhanced data management and data science. And this leads into innovation. So we are able to develop innovative medical devices, drugs, to develop new patient pathways for prevention and innovative care practice, and also in the field of e-health with telemonitoring and digital twins, all leading to personalized medicine. So our first pillar is a multidisciplinary basic research and medical community, which has a medical component with 11 medical specialty, with more than 100 medical doctors and 6 rare disease reference centers. And since the year 2012, cardiologists and endocrinologists work together under the umbrella of a single university hospital department. And we have a basic research component, which is on the downside of the slide, with 13 research teams and more than 200 researchers. Then our second pillar is state-of-the-art technological platform, and we have 8 technological platforms, including MRI imaging dedicated to research. And all our processes usually linked to multi-omics. So we have expertise in genomics, metabolomics, lipidomics. We have also expertise in the way to understand electric signals from the heart, from nutrition data. We also do preclinical disease modeling with organoid and stem cells, and we are all able to integrate this data using transfer learning and machine learning expertise that we have from Sorbonne University. Our third pillar is clinical cohorts, and we have more than 40,000 patients included in those clinical cohorts, ranging from reference population and primary prevention to rare disease and transplant. And in some of these cohorts, we have longitudinal data from some of the registry with over 10 years of follow-up. And from all these pillars, we have been able to build up more than nearly 30 major collaborative projects, including 2 transatlantic networks and 8 European initiatives, and 3 of those European initiatives are coordinated by ICAN researchers. So these are the project Metacardis, Maestria, which will be more detailed in a minute, and CMRI. And all these projects have been able to develop this emerging cardiometabolic field. So on the left, you see the evolution of reference domain, and you see that starting from year 2006, there has been an increase of publication dealing with cardiometabolic condition. And we have been able to drive some major scientific breakthrough, such as linking epicardial adipose tissue with atrial fibrillation. We have done some work also on microbiota, on cholesterol efflux, on cardiac MRI strain as a new non-invasive biomarker of fibrofatty level of the heart, and also to tackle fatty liver with atherosclerosis. And this has led into nearly 200 medical consensus articles and international recommendation from our medical community, more than 5,000 scientific and medical publications, with over 300 of these cited in the most 1% top journal. And we have been able to drive and to obtain nearly 40 million euros of competitive grant funding at the level of Europe and national France. And a second success is that it's fairly attractive for industrial partner. We have nearly 50% of our project and funding is directly linked to public-private partnerships, including in European competitive grant, such as Maestria. And we have a strong focus on the development of innovative biomarker, medical devices, and imaging. So here is our vision. So our vision is about our medical and scientific challenges. So the first challenge is the generation, implementation, and use of research of health data to integrate all this heterogeneous data, mainly coming from multi-omic and imaging using artificial intelligence approach, leading to the identification of novel biomarker and new disease modeling approaches ranging from organoids to digital twin. And we think that using these techniques and using the high-quality data compatible with state-of-the-art machine learning that we have through Sorbonne University, we will be able to develop better patient trajectories to improve the quality of life of patients. Our vision also is linked to medical care. So before, standard medical care was a really long process, in particular in cardiometabolic diseases, when you have to find a number of specialists, because people usually in cardiometabolic disease suffer from multiple morbidities, and they have to see different medical doctor specialists. And so between the first diagnostic and treatment, it usually took a long time, because you had to find rendezvous with the various specialists and to run a number of exams, wait for the result before you got the treatment. Now, today with IHU ICAN based care, all these specialists are actually developed into a team, and so it runs really faster between the patient and treatment. But of course, all these specialists are only accessible to top university hospitals, and it requires cutting-edge technological access. And we think that tomorrow, with artificial intelligence-powered care, it will be implemented in standard hospital, and also will have cost saving while enhancing quality of care, using in silico virtual specialist decision making and transfer learning from cutting edge technology to standard care techniques. Of course, in order to realize this, we will have to deal with big health data, which is a major challenge to build tomorrow's health, because large patient health data sets have to be harmonized among physicians, hospitals, and countries. So we have to deal from clinical research trial, research cohorts, hospital registry, to the medical information system that you can find in various health data hubs. Another aspect is that multi-omic and multimodality biomedical imaging generate a massive heterogeneous data. If you take, for example, next generation sequencing, it can lead up to 40 billion short reads of a number of base using these genomic or metagenomic techniques. And for images, for example, if you take a heart multi-chamber view in MRI, it's 15 slices of 40 time lapses. And if you go deeper into the analysis of hemodynamics to MRI 4D flux, you will end up with analyzing more than 1,000 high-resolution images. And of course, you need to get access to longitudinal data in order to build up this predictive model. You need to know what will happen to the patient. And so this is why we are using high-risk or rare disease patients to model most common chronic diseases. And the challenge of big health data is to be able to structure the data, label it, annotate it, store it, and make it accessible in accordance with the regulation in place. Which leads up to the challenge of medical big data and artificial intelligence, and of course with the ethical and legal challenge of artificial intelligence-driven personalized medicine. So artificial intelligence is actually an umbrella term, and under it, machine learning is a set of techniques and tools that allow computer to think by creating mathematical algorithms based on the accumulated data. And in unsupervised learning, the algorithms are not trained, are instead left to find regularities in input data without any instruction. So you have personalized data, then you have this kind of black box, which is a neural net, which will lead to an output, which is an individual decision. And of course, in Europe, we have all these rules about data protection and privacy, which are called GDPR, which is General Data Protection Regulation, which restrict the processing of personal data. So one is the purpose limitation. This is right, because for clinical research it is already purpose limited. So research clinical trial are able to find this rule. Then you have another rule from the GDPR, which is lawfulness. So for clinical research, we will need to recontact subject to inform them about the new purpose. Then you have data minimization. And of course, for artificial intelligence, they often tell you that we don't know which data is relevant before applying the algorithm to the input data. But the good thing is that clinical research is already pseudonymized. Of course, anonymization is something that is really complex and can be out of reach in most cases. And you have the right to explanation. So AI is actually black box, and so we will need to drive this from clinical research, which is evidence-based. And of course, you have all this data protection, impact assessment, and record of processing activity that needs to be documented. So here is an example of actually applying artificial intelligence to biomedical imaging data. And so it's a long data preparation process. So you have a clinical question. So you will need to identify the relevant data and the relevant patient. Then you will need to recover, clean and enrich the data. And of course, you will need to extract the imaging files, which is actually in the DICOM format, from a PACS system, which is picture archiving and communication system. You will need then to associate the clinical data from their information silos, whether it's in CRF for clinical trials, or whether it's in medical reports if you go from hospital. Then you will need to minimize, pseudonymize, or even anonymize all the data. So for the imaging file, you will have to do a de-identification process, because usually on the image or in the header of the file, you can find the name or a number of the patient label. And then you will have to do all the image post-processing to annotate, segment, and measure. And of course, this requires expert labeling through the use of a medical doctor or radiologists in order to be able to exploit and train the data using deep learning models that will lead to the algorithm. So you have to combine a medical with a research environment, and to combine all these data preparation that are usually done by data providers such as hospitals, with the data mining and the data user that comes from the artificial intelligence world, usually coming from universities. Now I will just briefly detail a selection of our major achievements. And the first one is about cardiometabolic imaging. So we have built a structural and functional multimodality imaging combining MRI, ultrasound, and scanner CT imaging. So with this, we are able to do anatomic strain, flux hemodynamic, and functional coupling, in particular using MRI and ultrasound. And we use also transfer learning techniques to be able to implement more detailed information in ultrasound coming from MRI, and for CTs and scanners, it's only to deal with anatomy, histology, such as, for example, fibrosis. So we have been able to build an excellence cluster in hemodynamic imaging of the heart and the aorta, breaking down barriers between medical discipline, engineering, data science, and artificial intelligence. And we have obtained a number of projects, and which I will come into more detail in a minute. For example, we are developing a population imaging atlas. So in the hospital, you have a number of patients, and you can actually develop non-invasive innovating biomarker, which are summarized below, but you actually don't know whether the utility of this biomarker, because you are only addressing patient population, and so you will need to have a live liver and heart imaging referent atlas with a normal subject coming from the general population to be able to test the sensibility and specificity of these various novel imaging biomarkers. And as an example of the work that we do in imaging, we have been able to imaging cardiometabolic risk in COVID-19 patients. So based on the fat and inflammation surrounding the heart, we have been able to develop an algorithm in order to predict whether a patient suffering from COVID-19 will end up in ICU units. And this work has been published. If we now shift to atrial fibrillation, and we have done over 20 years of collaborative research to be able to identify the physiopathological mechanisms, and we are now really ended up with precision medicine that is built upon clinical imaging and artificial intelligence. And for that, we have this European project that is led by Professor Stefan Attem, which is called Maestria, which is actually the building of a platform, a diagnostic platform for atrial fibrillation and stroke, to be able, which is driven by artificial intelligence, using standard care measurements such as ECGs, so electric signal imaging, using, for example, echography or scanner, and biological sample using standard biochemistry in order to develop novel algorithms that will enable precision medicine in this disease. So we are really going from theory to actual practice. And another example, which is through a novel patient pathway, which is the NASH clinic. So NASH stands for non-alcoholic steatohepatitis hepatitis, which is a liver disease, and linking care and research for the benefit of patients. So in this clinic, patients are willing to participate in research, will benefit from the additional clinical exploration and access to the most promising drug in development. And the drug will be chosen based on the patient profile. And of course, for the clinician and researcher, they will benefit from state-of-the-art clinical cohorts with imaging data and bioresources that can be used for multi-omics to better characterize, for example, metabolic liver cancers. So now going for collaboration with the United Arab Emirates. So we in the Emirates, you also have a growing prevalence of cardiometabolic diseases. Your health policy and organization have emphasized the need for innovative means to tackle this disease, and you are strongly fostering translational patient approach and the use of highest technologies, including artificial intelligence. And this actually represents an opportunity for our University Hospital Institute to further refine its novel non-invasive imaging or circulating biomarker or surrogates, our artificial intelligence algorithm for diagnosis and treatment of cardiometabolic disease, and innovating patient care pathways by taking into account population with distinct ethnic background, lifestyle, or socioeconomic condition with a high prevalence of cardiometabolic diseases and associated comorbidities. And we have selected three projects that we think could be developed in the United Arab Emirates. So we think that it's time for development of a clinical cohort, and we really think that the liver and heart imaging reference atlas could be a way forward, because the key benefits and feature of this project, it's a half-a-day clinical exploration, which lead to a full cardiometabolic checkup for participants, so they will benefit from this. It's state-of-the-art multimodality imaging, and together with blood biobanking for multiomics, it's highly suitable for artificial intelligence implementation. A pilot study is actually accessible to a unique center, so you just need around 2,000 participants, and it's easily scalable to multi-site, and it's a starting point for longitudinal follow-up. Another thing that could also be developed is to develop projects such as Maestria, so this diagnostic digital platform, which is a multidisciplinary project bringing together basic science, engineers, data scientists, and medical doctors, driving a whole ecosystem of industrial partners. So in the Maestria consortium, we have 6 or 7 small and medical entities and a huge medical imaging partner, which is Siemens. We can build up a prospective cohort using standard care data, so you don't need access to latest technologies. So by just using standard hospital data with ECG, ultrasound, and blood biochemistry, you can be able to expand the algorithm to the best interest of the Emirati population. And of course, we think that it's time for bridging universities and hospitals in the Emirates to have a thematic autonomous university hospital institute driving healthcare ecosystem growth. So ICAN could provide support to Emirati organizations willing to adapt this model to their specific needs. So it's a manageable size. You don't need many people for operation. You just need a small starting community of about less than 100 scientists and medical doctors. It can be a wall-less institute. It's a reasonable investment driving science and medical education with a return on investment through the establishments of international partnerships and attraction of industrial partners. And in conclusion, we think that the take-home message is bringing together scientific and medical research through decompartmentalization fosters healthcare innovation to patient and drive the growth of an healthcare industrial ecosystem. Requesting back the control, so sorry for this technical problem. So by implementation of state-of-the-art 21st century innovative project requires dedicated multidisciplinary teams for project management, legal, regulatory, and tech transfer for this collaborative research and valorization. It's easy to expand care data to clinical research cohort, allowing for in-depth phenotyping through multi-omic and multimodality imaging, and this is key for data science and artificial intelligence. And this can all be achieved by creating thematic university hospital institutes such as ICAN. So, yes, and this is just a small number of our teams, our medical and researchers. And I would like to thank French Healthcare for giving us the opportunity to present our institution and work. I don't know if there's any questions from the audience. We are willing to answer any questions.
Thank you very much. There are no questions. Thank you very much.
Thank you very much for everybody's attention, and sorry about the major glitch there has been in the presentation. I think some of the parts were not easily readable, and I hope if you've got any question, please feel free to ask them.
I'm delighted and proud to launch and lead this conference dedicated to the French health innovations to help under medicalized areas. So we are together for 1 hour and a half, and we've got 3 panelists here and 3 panelists remote. Okay, so it will be a very interesting game to play, how to mix this kind of approach. So, but it will be a success. Okay, I would like to thank a lot first French Healthcare Association, a very dynamic association, and help in particular Elisabeth Arnaud and Joanna Lerfeld that are leading this association very successfully. So I will make a quick introduction about the context of our group to help under medicalized areas. And after we will have 7 presentations for very, very innovative solutions we have on services we've got in France. And we are, as you know, a good healthcare and social protection system in France, but we have also some problems or under-medicalized areas. And for instance, for each solution we are presenting here today is also in France. But we will be very proud to help other countries to get better situations. So, by my side, CAISA I'm the president of CAISA. We help firms, organizations, France and abroad, and to implement services for e-health, but not only e-health, to help for under-medicalized areas, and to make the link with the solution services and how to implement financial response or answers also. Okay, so today I have the pleasure to have on our side different, very innovative solutions from France and services from France. I discovered recently a firm called Noradom. Noradom, and Professor Gilles Kemoun is the president and founder of Noradom. Is for telerehabilitation. We will see a quick video of that firm. After Dr. Mehdi from France is in remote situation. Mehdi, it's a really wonderful innovation from France called EcoPen, and he will present us for 3 minutes. 3 minutes. And of course, in France, we've got a lot of startup very successfully, but also champions. We've got our champions called, for instance, Orange, and Innovacom is the e-health activity of Orange all over the world. So Simon Chassin with us today. After H4D, in my opinion, H4D, H4D in English, it's the best solution in France for medical cabins for services, clinical services, and maybe in Europe. H4D, Franck Bonino, the founder, is with us. After TLM 360, okay, a good expertise all over the world for how to implement, because it's very important to know how to implement e-services. Quantic, it's also with Alain Abra, a wonderful solution, very innovative. It's a licorne for France, I think, it's a future licorne for France. And then we will finish with Professor Antoine Tenière. It's a clear demonstration how in France we are promoting, we are helping our licornes on startup and firms that want to make excellence all over the world from healthcare, and particularly for e-health. And so Professor Tenière is with us too. So first, Noradom for 2 minutes. His name is Roland. Roland is in the rehabilitation process. And as you can see, he's in front of a screen at home, making very easy exercises. And he can have a short discussion with a physician after this exercise. So it was a very short description. And maybe you can present now EcoPen.
Definitely, yeah. You can hear me right well?
That's wonderful. We see you.
Okay, excellent. So I request the control and can move forward to the presentation. I'm very thrilled to present you EcoPen Factory. Thank you, Franck, for this introduction. We're developing here, let me pass the other. Wow, I passed it too quickly. Yes. This way, it's very sensitive. So we're doing basically ultrasound imaging, and our goal is to make it accessible all around the world. And we're developing a device, a connected device that you can see here, connected to any kind of smartphone, and dedicated to orientation diagnosis. I will say a few words in a bit. Let's have a glance at the worldwide problem. 2/3 of the worldwide population do not have access to medical imaging. And here, the potential targets as healthcare professional is about 70 million of healthcare professionals that can be users of this kind of solution. What we're addressing here, more specifically, is to answer two very basic questions that any kind of medical practitioner answers himself when he meets a patient. The two questions are, is the condition serious or not? Which organ are damaged? This is really the two fundamentals wherever we are, whatever medicine, whatever patient, whatever MD, these are the two very basic questions. And this device enables you to see inside the body and to answer those very basic questions. You can see here the device connected wireless to any kind of smartphone. And if there is a technical audience, let's say a medical audience, we have 3 probes into one, which enables us to get an image from the bottom to the top at any depth. So it's really very convenient. We augment the solution with AI-based services to enable a better image quality, to enable a better gesture for the medical doctor, and also diagnosis assistance. Where we are now is we're expecting a launch really soon. We finished the industrialization, and we'll be happy to take the world by storm, because in this after COVID and hopefully after COVID situation, there are really a strong trend to make ultrasound handheld devices available anywhere in the world, and we are the one targeting this ambition.
Thank you, Mehdi. It was very clear. Stay with us, please. We will have some questions, of course. Okay. So, Simon, right now? Simon Chassin from Orange Innovacom, large group, champion of France.
Hello, everyone. I'm Simon Chassin. I'm representing Innovacom. We are the IHU branch of the group. For people who don't know Orange, this is a telecommunication operator operating in 26 countries and globally over the world with Orange Business Services. A few figures: this is 42 billion of revenue worldwide, 260 million customers around the world, and 142,000 employees supporting this activity every day. And on our side at Innovacom, so like I said, we are the health branch, so we are leading the B2B offering of the group, and we are actually developing some software solution that take care of data in general. This is what we call interoperability. This is a strange word that make communication between systems that doesn't speak the same language. And actually, we developed some solution that should help healthcare provider to save more time for better care. Let's start the. Okay. So to address under medicalized areas, I think first thing is to implement some foundation to make actually a communication between the local facility, the underserved area, with the expert facility, the support facility. For that, we need to implement some connectivity. So the first thing is the network to make a communication possible between the two facilities. So it needs internet connection, but also 4G, 5G, and what we call LAN-to-LAN connectivity that allow the local facility to access the information. Like you know, maybe IT infrastructure are very costly. Pricing are going up, and we can see that the cloud solution can really be an enabler to facilitate fast implementation. And as you also know, medical information are quite valuable. There is a lot of threats around this information, so we really need to make sure that there is the right cybersecurity around all that connectivity, and this is everything that Orange can provide globally in the country we are actually operating, but also worldwide. Once the connectivity is okay.
The remote device is not really connected right now.
Okay. So this was the Orange group expertise and knowledge to make sure that we can connect local facility. Now we also need to take care and to make sure that there is a continuity of information between the local facility and the facility that will support in terms of medical expertise. We need to make sure that the information is shared among these two facilities before the patient care, also during, of course, but also after, making sure that the healthcare professional, the healthcare experts will access all the medical file. There is also a huge need in terms of information sharing with the global ecosystem, which include the doctor in the city, payers, third-party health providers, the health record, the national health record when it does exist in the country. All this continuity of information topics needs some requirements, and I think it's a lot has to be done at a national level. We need a real policy for that. We need a patient ID, so we can make sure that we are talking about the right patient. We need some standards, and it has a huge role to play around that. And the last thing I think that is very interesting to mention is to use the mobile to make this happen, because as you may know, in some areas they've made a huge jump between nothing and mobile. This is not maybe the case in Europe, but in some countries there was nothing, and now they are all using mobile thanks to the network again. And I think this is really important to keep that in mind, to make this to achieve this target of addressing the underserved medical areas. And we can actually talk about two cases. Here at Innovacom, we are developing a mobile application that allows the patient to digitalize the relationship with the healthcare facility. For example, to make the online checking. We can say that like for the airport, so making sure that he is giving the right information in terms of administrative paper. And then you can also book an appointment with the provider, and then pay for the healthcare service. By the way, in terms of payment, Orange has a strong solution which is called Orange Money, which is widely used in Africa, but also now in Europe. And I will talk a bit more about that just after, I think. Yeah, here we are. So Orange Money has been created like, let's find my notes, sorry. And it has been launched in 2008 in Ivory Coast first, and now it's 60 million customers in 17 countries. It's all about actually financial services, a way of making some payment using mobile application, short text message, and it's working in this region because it's based on digital, it's secure, immediate, and cheap. So this is the magic recipe to make this happen. So you can make some payment and include some financial services. Okay. So, for example, in Ivory Coast, you can make you can actually buy some complementary insurance directly from Orange Money, and in Cameroon, you can also pay some insurance. So there is some partner that are compliant or compatible with this way of payment, and this is a way, I think, to increase this this value. And the last topic I would like to share with you is just to illustrate that it's possible to connect actually multiple multiple facilities to a national information system. We've been part at Innovacom during the crisis. We've been part of the national screening platform for COVID testing. And actually, we have connected all laboratories and hospitals that were making some COVID testing. We have connected them to the national platform. So every day we are collecting something like 500,000 COVID tests. We centralize them. We make sure of the quality, and then we send this information to Santé Publique France, which is more or less the MOH. We send that to the Social Security for contact tracing, and they are also using this platform for day-to-day analytics and all the figures they are providing every day. So this was only to demonstrate that there is some solution, and I think at Orange we can really be of some help to make this challenge achieved and addressed correctly.
Thank you, Simon Chassin from Innovacom Orange Group. So I wanted to add that for under medical areas, to spread health services, it's very important that the co-payment or no payment could be useful. And
sure.
In Ivory Coast especially, you are very implemented there. That's very important for under medicalized area to be sure that there is a guarantee of to produce and to provide some health services. That's very important. Okay. Okay, thank you, Simon.
You're welcome.
I'm sure you will have some questions from the auditors. Frank Bodino. Nice to hear you, Frank.
Hello, everybody.
Okay. You've got 10 minutes also. Thank you.
Okay, I just request the control. Okay, so I'm very happy to be here with you today. Good morning, everybody. My name is Frank Bodino. I'm a medical doctor, and I created H4D in 2008. As a physician, I had the chance to work in different countries, in Africa, in Asia, in Australia, in Canada, and I identified the same problems, that was how to access to health for population at large. And in 2006, I had the idea to combine new technology with this winning, and I invented the first connected medical office that is called the Consult Station. And in 2008, I created H4D. Yes, can you hear me?
Perfectly.
Okay. So today H4D, it's a French company based in Paris, but we have developed the company in different countries, in France, in Italy, in Portugal, in Estonia, in the UK, and we just started in Middle East also. So apart from the technology, for us, telemedicine, it's global services. Means we need to have the best technology. So today in Europe, we are the only booth that is fully certified. And we are also FDA certified for North America. Means you can use this securely for both patient and physician. But also we need care coordination. So it means that we don't put the station in underserved areas or for our corporate clients, but we every time build medical programs. And the third pillar of our company, it's the H4D Academy. So during the 9 last years, we've been training physicians because we analyzed medical protocols, North American and European protocols, to know how to train a physician. Because as a physician, believe me, it's not the same thing to do a face-to-face consultation than to do a remote consultation. And it's not only how to guide the patient, how to use remotely devices, but it's also how to do a stomach examination, shoulder examination, etc., etc. So we do ongoing training for the physician. So behind the technology, we do primary care, occupational health, and preventive care. So what a consultation is? So today it's considered as a kind of microclinic. We implement the consultation on small villages, but also for corporate clients and also on hospitals. As you can see, you can use two modes of use. The first one is to do a self-made checkup. So the patient book an appointment, he go into the cabin and is guided by video tutorials. It takes between 10 to 20 minutes, and it's very useful to do preventive programs, but also to do triage in hospitals, for example. And the second mode of use, it's the teleconsultation. So at this point, you don't have video tutorials, but you're in live with a remote physician who is a GP or a specialist. So how does it work? As a patient, you're going to book an appointment through your mobile or using an internet website. You go into the cabin, you put your insurance card or your credit card, depending on the country where you live. You choose your language and you're connected live with a remote physician. The physician will ask you the classical question, how are you today, what's the problem with you? We will ask you for all your medical story, and we'll start the consultation. The consultation. At the end, you will receive directly into the station the prescription, if it's needed, or on your personal website. So I wanted to show you a movie. I don't know if it works. I don't think so. So the service is provided 7 days per week, all during the year, in each country we work. In France, it's a mistake. We have almost 300 implementation, and we have almost 20,000 consultation every month. You have to understand that it's completely different than what we comparing on what you can do just by video conference, because this is clinical telemedicine. It means you don't have just an advice from your physician, but it's a complete consultation that is completely different. It takes between 12 to 15 minutes for the physician to do his consultation. So as you can see, we have different locations in France, and in different countries, we work with local authorities or national authorities on medical plans. I already told you that we can do primary care, acute illness, occupational health, etc., etc. In fact, we build every time the medical projects. This is the kind of diagnosis we did on the pods. And not only on the pods, but we develop full scope of solutions. We have this consult station that is considered as a microclinic, but we also have a small pod. And now we developed a home kit to be able to follow up the patients till home. Those were examples of kind of diagnoses we can do, because we work not only with GPs, but also with cardiologists, with dermatologists, with psychiatrists. And there are pictures on how it works. So you can see that everything is certified, especially during this COVID period. It's super useful because you don't have a waiting room. So you arrive as a patient, you take place on the station, and you can have your teleconsultation. We have a very high rate of use, both from patients and physicians. And physicians really appreciate that we train them to know how to use not only the technology, but how to improve their know-how on guiding the patients and do a clinical examination remotely. So this technology is fully certified. It's very safe and accessible for patients and physicians. Thank you very much. And this is a few examples of big corporate clients or region we work with. Thank you very much.
Thank you, Frank. I know that unfortunately you've got a meeting just after, so we can't send you some questions from the auditor. So I can make a testimonial on your. We recently, with my team, we made an assessment of the use in an under-medicalized area in France. And the result was very interesting. 30% of people told us that because of the use of this clinical microclinic of H4D, 30% decide not to go to the emergency services, healthcare services. So it was really a big success, and more, months after months, people were involved to get an access in your cabin. It was a big success for this under-medicalized region in France. So thank you very much, Frank. One very simple question. What is the main difference between H4D and your main competitors all over the world?
The clinical aspect and the medical training, I think. First of all, because usually patients use just video conference. So as a physician, I don't know how you can just treat simple throat or chest pain or a ear pain just using a video conference. You need medical tools. You need to be trained as a physician. So this is the main difference. And the third one, it's that we don't just implement the technology. Every time we build a medical program with local partners, clinic partners, hospitals, and authorities. This is super important because we can coordinate care also.
Then, thank you, it's very clear. May I give you information for people from international areas, that in France we've got, as you know, a good level of expertise for medical services, social protection and so on. So when you create something in France, like innovation in healthcare services, you've got a lot of expectations, of constraints for technical, medical constraints, security, confidentiality constraints. So when you go abroad, when you go to export your solutions, the clients could be sure that you've got a high level of expectation, very high level of expectations you have in front of us. On the H4D, it's a very good example, like other solutions, of course. And we've got our champion Orange. You know, especially that you can't make confidentiality be sure for people that you are using French solutions. So thank you, Frank. Bye-bye. We will send you some questions from people connected and here in Dubai. So Robin, can you some word about TLM 360 in French, 3060 in English? Push on the little button? No? Okay. Can you push on the little button there, please? Thank you. Go to the picture of Robin Ohanessian.
Okay, thank you, Frank. Thank you, everyone, for this meeting. So I'm Dr. Robin Ohanessian. I'm a medical doctor specialized in public health and CEO and co-founder of Telemedicine 360. Yes, so the title of our presentation today was about mostly supporting governments in promoting sustainable telehealth, especially in this frame of the Expo 2020 and international and global presentations. So our specialty is mostly on telehealth and telemedicine, and as you know, and it was presented by our colleague Frank just before, telehealth is a remote medical practice which has been developed since many years. It's not new, however, since the COVID pandemic has been widely accepted and widely promoted and used in all over the world, in Europe, Africa, and Middle East as well. However, for telehealth to grow and be sustainable, it requires many infrastructure settings, such as legal, technical, and financial infrastructure. And despite what we have seen in terms of growth of telehealth during these past 2 years, all around the world, what we know as well is that without the right infrastructure and environment, this cannot grow further in the whole spectrum of telehealth, and not just only video consultation, but as a more widely spectrum of medical activity. So many countries actually initiated temporary telehealth rules and standards since 2020 in many countries of the world. However, most of them were temporary in nature and not completely designed to be for all the time. Such countries, for example, who did not allow telemedicine before the pandemic, did temporary regulations to allow it during the pandemic, but now it has to grow further. Such countries, for example, are Brazil or South Korea, which before the pandemic did not allow telemedicine. They changed it, but now what's next? So this needs to be broadened and expanded to actually support the long-term growth of telehealth, and also allow new type of activities, new types of projects, without having restrictive regulations. Why? Because every day we have new innovations, we have new startups and companies developing new technologies, and we should not develop regulation and standards which are too restrictive to allow those new
C'est bon. Eh bien, voilà. Alors, Simon, bon, on va 2-3 minutes, hein, on va terminer. Désolé pour cette interruption d'image hein, et de son surtout. I'm sorry about that. Okay, I have to switch in English. Oh, sorry. I was a little bit disturbed. So, Simon, 3 minutes to close your presentation, please, because of this.
Robin.
No
problem. Sorry. We're all together today. So I was saying that actually France is a global leader in telehealth. Why? Because it's been legal practice since 2009, and we're one of the country with the oldest regulations on telehealth, which allowed the country to grow and go more and more complex with time. Just as an example, in 2020, there was 19 million video teleconsultation which were reimbursed and paid by the National Public Health Insurance. So this is publicly funded, and there were many more that were actually also paid directly by the patient. And so we have an advanced expertise to share with the world, and we're the proof here in this session with many companies with 10 years experience, more than 100 startup company, and more than 500 millions of public investment since this 10-year time. So at Telemedicine 360, what we do is to support public and private organizations to develop quality and sustainable telehealth since 2015. We have helped the growth of telehealth around the world in Europe, Africa, Asia, and here in the Middle East. And what we do is that we start from national strategy all the way to valorization and demonstrating the added value of telehealth activities with 3 services: Telemed, Start, Audit, and Eval. So what we wanted to show is 3 very quick international case studies of the work we have been doing in Kingdom of Saudi Arabia, Republic of Fiji, and Senegal. So we've been very proud to work on Saudi Arabia national strategy and regulations for telehealth all the way to the national telehealth guidelines, which have been published very recently. The Republic of Fiji, where we helped the Ministry of Health in developing telemedicine policy, guidelines, and national group. And as well in Senegal, where we worked on the first telehealth diabetic retinopathy screening, also with the Ministry of Health and supported and funded by the UN. So as a last point, we also contribute to science and digital health research, because we think it's very important to combine the innovation of the technology and as well the science and the medical to support and to back it. And we actually published one of the most cited research on telehealth and COVID, with more than 600 citations so far. So let's choose France and let's expand telehealth together. Thank you.
Thank you very much, Robin. So in France, we've got technology, solutions, services, and expertise is a high level also. Okay. So, Alain, the first time I met Alain, I used your technology. I was very impressed. Can you describe it very quickly? We've got 10 minutes, so we will ask
just a question
after.
Thank you. So I'm Alain, the CEO of Quantic. Quantic is a company that I have created with Fabien Niel, who is my great co-founder. So I want to tell just something about him. Anyway, Quantic turns any camera, and especially any smartphone, into a medical device. So the idea is you take your smartphone, you look at your smartphone for 20 seconds, and we measure your vitals, such as the heart rate, your respiratory rate, and soon your SpO2, your blood pressure, and other vitals. So this is not magic. So if you may, I can perhaps explain why it's not magic. So I guess you know what is now an oximeter. So an oximeter, you put the oximeter on your finger, and it emits a light. So we are not an oximeter, but it's just the idea. And so the oximeter just measures the absorption of the light by the blood circulating on your finger. And when your heart beats, you have more volume of blood in your finger, so more absorption, and so the oximeter sees a pike, and so he can deduce your heart rate. We do exactly the same, but with the ambient light, so we measure the absorption of the ambient light by the blood circulating in your face. So it's just for an explanation. So it's a great technology, but for what? So obviously for home care, like prevention, like remote consultation, and also for remote patient monitoring. So this example of a remote patient monitoring is particularly important. So let me precise with examples. I guess you have about 2 billion people in the world suffering from chronic diseases. So it's the first cause of death in the world. Remote patient monitoring is a key for improving that. So it has been demonstrated that it has been demonstrated that remote patient monitoring improve the rehospitalization. So it decreases rehospitalization, it improves the life expectancy, it's also improve the wellness of the patient. So what it's also called RPM is really important. However, it's limited by design. It means that for checking the patient health remotely, you need hardware, medical devices. So it means that the model is limited by design, so the model is not scalable. So that's what we change. Practically, we sell an API. So this API, an API is a piece of software that anyone, so any e-health solution provider can integrate into their product. So it means that anyone can enrich their solution with remote vital monitoring. And it's especially important for under-medicalized countries where when I talked about RPM, yes, but so it's difficult, but it's impossible in such countries. So it makes this possible. To success, so we need money, that's why we are raising funds, but also we need very good partners, great partners all over the world. So that's what, sorry for this.
That's okay.
But we need partners. So we already have partners, and just as an example, the next year we have planned to work with 16 hospitals in France, but also in several countries in Africa. So the last point is important because, so why? First, because such a technology should work with everyone and with every skin color. So that's why we have already tested the solution with more than 1,000 people in Congo, RDC, and we continue. So this is the first reason. And the second reason is when we say that we want to help so under-medicalized countries, we need to work with them and we need to be there from the beginning. So that's what we do. Thank you.
That's very clear. I've got one question.
Okay.
Where are you located?
In Paris, France, at Paris Santé Campus.
That's a wonderful transition. Okay. Yeah, Paris Santé Campus. Professor Antoine Tenière, you are with us?
Absolutely, Frank. Hi.
Hi, Antoine. Okay, so you've got Quantic and Alhambra in your site. What is exactly Paris Santé Campus? It's a very new and a huge innovation in France. So can you describe Paris Santé Campus in a few words?
Absolutely. Thank you very much, Frank, for this great invitation. And I'm really happy to be sharing some of the latest advances in France involvement to push forward the digital transformation of healthcare. So Alain is part of our community, but Frank as well, Frank Bodino, who has presented H4D. And the idea of Paris Santé Campus is to create a unique center dedicated to digital health, based on the concept that gathering expertise through entrepreneurs, through researchers, through caregivers, through institutions is one of the key in accelerating progress in digital health. And so Paris Santé Campus just opened at the end of 2021 and is designed to welcome more than 1,000 people dedicated to digital health and accelerate healthcare transformation in France by federating all the key players in the national territory and have them work internationally, of course, as part of important mission in health for France. So let me just see, yes. So the idea of Paris Santé Campus has been promoted by the French President Emmanuel Macron, and the program has been announced at the end of 2020. Basically, the program was pre-existing the COVID-19 crisis, but everyone in the world, and especially in France, could see how digital health, through the example that have been presented today, for example, have provided solutions to this pandemic crisis. And of course, the COVID-19 crisis made it more and more urgent to push forward this kind of initiative. And 1 year after, we were able to open the first emblematic site in the heart of Paris to welcome all the expertise from research, from care system, from industrial partners, from entrepreneurs, and from French institutions to gather in one site and work together on promoting digital health. And so basically, 4 main objectives that Paris Santé Campus will address. One large objective on data in healthcare. Of course, when you think of digital health, promoting data collection, data storage, data analysis, data protection is absolutely essential, and it's the fuel to promote and advance digital transformation of healthcare. So this is our first objective. The second one is to be able to create tomorrow's talents and identify the key skills that will be necessary to advance digital health and create innovative and reference training for France and to a larger extent for international collaboration for digital health. The third main objective is value creation, and I think you had a great examples through the different presentations today, how the exceptional French startup tissue or ecosystem is moving fast forward and creating value through digital health. And the last objective, of course, is to make sure that digital transformation of healthcare really serves improvement in a patient-centered conception of health system. And so in line with this main objective, a number of tools are available today. 5 public players that are really key in France for research, for training, and for healthcare, and especially digital health, are gathering together to promote Paris Santé Campus, to support 4 research institutes located within the center, and at its final stage. The goal is to welcome more than 100 companies in a center designed specifically for healthcare and digital transformation that is 70,000 square meter large, that is currently under renovation with a large budget where public funding is partially invested to promote digital transformation of healthcare. Among the key players that I mentioned, for those who know the French ecosystem, INSERM is the National Institute for Health Research, INRIA is the National Institute for Digital Research. Université PSL is one of the key representatives for healthcare training excellence, in France. And the Health Data Hub is a structure that is in charge of collecting national data connected to the Caisse nationale d'assurance maladie. France has one of the largest data sets in healthcare that is organized through a public structure that is connected to the HIAP data hub, and the Agence numérique de santé is also in charge of promoting healthcare transformation. And through these 5 public key players in France, the relevant state department or ministries involved are depicted on this slide. Research, higher education, healthcare, and economy are heavily involved in the supporting Paris Santé Campus. Basically, among the 4 research institutes, researchers gather one of the best expertise in the world around digital health. The first institute is called Prairie. Prairie is dedicated to AI in health and understanding how algorithm can improve the healthcare system. The second institute is working on quantitative biology and digital modelization, so, for example, digital twins applied to a biologic system. The third institute is dedicated to imaging, that is under strong evolution with data. And the last one, which is very important, is dedicated to understand all the impact of digital transformation in sociological questions, in economic questions, and in philosophical questions for new modern society. So these institutes will collaborate with a large set of startups, small companies, and large industrial groups that are gathering Paris Santé Campus and promoting a large gathering of expertise on site. And of course, you've understood through what I've explained that one of the main concepts is to be able to assemble expertise in data, innovation, research, care, education, and companies through this exceptional initiative. Of course, the idea is not only to gather and to assemble French expertise, but also to have a large network of collaboration and very active international outreach. And in line with this, I'm really happy to be presenting you this program. And one of the first set of expansion is, of course, the European Union, but to a larger extent through academic and industrial collaboration, to also create a worldwide network dedicated to promote digital health. So the first center has opened, as I said, at the late 2021. So you have a picture of this first center, and we're happy to be welcoming all of you who would like to visit one in Paris to see how this ecosystem is building and is producing and is creating synergistic views of digital health and digital transformation. So this is an example of the setting of the building, and you can see how academic research labs, how caregivers, how companies are fully intricated, and a large atrium in the center of the building is really helpful for us to create this campus life that we are animating to promote meetings. And Frank can actually testify that meeting researchers and other people that you usually don't meet is absolutely essential to advance innovation. Of course, there's a unique value proposition for industrial that would like to join Paris Santé Campus. And so we have entry points for startups, as I said, but also for larger companies and to big French groups that would like to help and think strategic axis of digital transformation with the French institutions. And so we're in the process of gathering this large players and starting our first programs. And I think, yes, I have a few views of the building that you can see through this video, and a number of testimony that we have gathered through students, through researchers, through startup companies, through larger groups, and through institutions that are actually explaining why they would like to join Paris Santé Campus and what value it can bring for their business, for their research, for their training programs, etc. And I think in line with this, I am done with my presentation. Of course, Paris Santé Campus is a great community that put in value diversity and investment in digital health. So we're happy to be welcoming new players that will add living ideas to this community. And I would like to thank you for your attention.
Thank you very much, Antoine. It was very clear, interesting, beautiful picture and videos also. Okay, thank you very much. You can send by chat some questions. We've got one, and Noémie, our friend based in France, actually located in France. We've got some questions, and I will share with you some questions and distribute some questions. Mehdi, are you always with us, Mehdi?
Yeah.
Okay. Mehdi, can you tell us who are the stakeholders, the shareholders of your company? Because it's a very specific approach in France, a new one. Who is the main stakeholder or the new stakeholder?
So we have something like really singular in our story, where APHP, which is Assistance Publique des Hôpitaux de Paris, which is actually the largest hospital group in Europe, who is part of the company, which is something like it happened for the first time with us. And we value this so much, first because the step we are now to having been developing in our device in the condition of costs that we were targeting, it was really possible because of the medical community of APHP. And beside, APHP is also for us a great way to deploy and to validate the usage. APHP is both something like 10,000 medical doctors, 20,000 MDs. It is strongly connected to universities, so that the students will be able to also be trained with this kind of devices that we brought to, let's say, a price of a stethoscope. And also APHP is a strong network of homologous hospital group at the level of Europe, of the level of other places in the world, West Africa, South America, and also Southeast Asia. So that for us is a tremendous chance to develop in the right condition this technology to really to be the more helpful for the medical doctors, the paramedics, and to be obviously the more best way to take care of the patients. On the other side, from more academic side, we're doing obviously a lot of R&D, and we have 5 top-level European labs that will be working on those like 3 years, based in Belgium, based in Netherlands, in Switzerland, in France. So that we have I think the right partners to develop our technology and to deploy to the market.
That's why I wanted to highlight this point, because if you want to buy some solutions from EcoPen, you have a powerful organization behind EcoPen. It's more than 100 people are working. It's international development also with APHP. So it's just EcoPen. It's all the French hospitals from the Ile-de-France in France that is with you to buy and to implement EcoPen. That's very, very important. That's the big power behind EcoPen. Okay.
Yeah. Exactly.
So I'm here for make promotion of super system in France also, you know. Okay, thank you, Mehdi. I've got another question. Don't quit the discussion. Simon. Yeah. Okay. I'm a director of hospital, of an hospital, for instance, in Dubai, or I don't know, don't bother. What are the added value you can propose to me? What kind of services? Because I need to exchange information, data with medicines, physicians around my hospital. What kind of services do you propose?
Well, I think one of the most important value we can provide to any hospitals is to allow the healthcare professional to save time. You know that data integration is a way to avoid some multiple entry into the information system. Very oftenly, when an hospital gets digitalized for the first time, it's bringing more task for the healthcare professional, which is a little bit frustrating because IT or digital has to be something that allow more productivity or more efficiency. So that's a bit frustrating for them. So this is where we come, and we provide some additional solution, intermediate solution that will help the healthcare professional to save time and be more more digital fan, I would say.
Okay. Do you know how many people in Ivory Coast or Senegal, both if you want, are using daily your solution to get an access to something especially for healthcare services?
That's a good question. I think this is quite a lot because Orange is operating as a mobile operator, telecom operator over there, and yeah, I don't have this figure in my mind, but
okay. I remember that in Africa last year more than 600 million people are getting to the new mobile. So it's a huge interest to get an access to healthcare. That's maybe the more useful activities with the mobile at the end. Okay, thank you. Sorry,
you're welcome.
I've got other questions. Okay, and I've got to you from Robin one question right now. Noemi, you've got a question. You tell the question from the auditors. Or?
Yes. Hello.
It's for Robin, I think, this question.
For now, there is one question from the audience on the live chat. They were wondering if the telemonitoring of patients will be reimbursed in the United Arab Emirates, and if yes, what are the challenges in diabetes?
It's for Robin.
Okay.
Yes.
Thank you, Noemi. Thank you, Noemi.
Thank you.
Yes, thank you for the questions. So the landscape in the UAE for telehealth reimbursement is actually quite interesting because it is firstly mostly driven by health insurance and less by public reimbursement. However, there are different things to consider. Firstly, in your question is what do we consider as remote monitoring? Because remote monitoring can be done through video consultation, periodically done. It can be done automatically with a hardware device. It can be done with questionnaire, what we understand as remote patient monitoring, with or without devices. And then when we take into account remote patient monitoring for diabetes, the most common acceptance is the glucose monitoring, continuous monitoring. I don't know exactly what will be the future in UAE for this reimbursement, but I hope that it will come to light so that the patient in the country and more globally as well in other countries of the Middle East can access to these services, which has proven to be effective in reducing complications.
I think that more and more in this region in particular, the TPA, third-party administration operators, could be very involved in how to get, in fact, the healthcare services with e-health, especially in Saudi Arabia. Alain Abra, Quantique. How many competitors have you got in the world? Do you know?
How many exactly? I'm not sure, but I can say that we have 1, 2, 3, 4 for really important competitors. I don't say that we don't have others, but that's the one we take care about. Yeah.
And why you will win? What are the differences? What are your skills? What are your...
So the first thing is we are very confident in our precision. The accuracy of our measures are very good, and that's also why we are tested in France and in other countries, and especially so in some African countries, because it must work with all skin colors, what I said before, and that's why also I'm so confident.
Okay. Maybe you can mention that to be placed, to be in the Paris Santé Campus, it's also a skill for you, maybe? An advantage?
Yeah, it's more than an advantage. So yes, so since we are there, we really understand that. So it's not just about network; it's about really working together. If you have a question, if you want to discuss with someone who understands. So the regulations or how to deploy somewhere in France, you can discuss over there. So yes, there are really good partners, but they are not the only partners we have. That's why we need to work with hospitals and physicians. So obviously we need to work with a lot of physicians. That's what we do, and some more other partners I could talk about later.
Okay, okay. Antoine, there is a lot of people from Dubai that are knocking at our door there. They want to go to Paris because they saw your presentation. They are very impressed. And what kind of possibilities you can propose to, for instance, a lot of Dubai director of hospitals, insurance companies wants to show in the same place what is the better expertise, better solution in France. What is possible? Is it possible to visit you to have some that kind of services?
Of course, Frank. Thank you very much for your interest in Paris Santé Campus. I'm happy to organize a group visit or an official visit, depending on the level of representation that UAE wants to provide at Paris Santé Campus. And I think it's a great opportunity for us not only to present Paris Santé Campus, but more importantly to see with our UAE friends how we can promote joint collaboration or joint expertise on digital health. So I will pass my contact information, and I'm happy to coordinate this through the French Healthcare Association, of course.
Okay, people are outside, knocking at the door. They ask me, is it free of charge? They have to pay to go to France. Of course, their ticket fly, but they have to pay to the entrance of Paris Santé Campus for this organization of presentation and so on?
No, we of course we're happy to invite people to visit Paris Santé Campus for free. There's no need to pay at the entrance.
It's okay. They will come. They will come. Thank you very much. Alain, one more question. Who are exactly your clients? Because in front of us, you've got a lot of people. Maybe 10,000 people told me, Noemi. You want to sell something. We understood, but
yeah. Okay. So our clients are the all e-health solution providers. So especially the one who are doing remote patient monitoring, we talked about that, but also remote consultations. Some others are doing triage in emergencies. So this is another application. And practically we sell the an API so that can integrate this in their product. So actually, if they want to have remote measurement, they just take this piece of software, put in their product, and seamlessly in 1 hour it's done.
Okay, and to be concrete, those people are interested. They ask me, is it expensive, your solution? The IPA is expensive.
So it's actually so it's not like start like that, but we adapt our model to the model of our clients. So let me give you an example. So obviously, if you discuss with teleconsultation platform, often their model is payment per physician. So we adapt. And if it's for remote patient monitoring, often it's per patient, so we adapt as well. So, and so they pay when it's used. So actually, it should not be expensive at all.
Okay, so I've got a question because, as you know, in every continent, people are very aware about data privacy. On more and more continents like China, Russia, and so on, the United States, of course, so are protecting their databases, especially for healthcare databases. So if I buy your solution, and for instance, in China, my data will be sent to French databases, a French cloud or something?
So we cannot think like that, you're right. We need to adapt to the country, to the culture. So obviously, if we sell to China and they want to have the database over there, the database will be over there. If they want the process to be over there, because actually it's a SaaS API, the process will be done in China as well. So we need to adapt. In France, we need to have servers in France. In the US, we need to have the server over there as well.
Mehdi, you are there?
Yeah, I'm there.
Still there. Same question for you, Mehdi. If I'm a Chinese insurance company, and I want to propose it to my reimbursement scheme. So if I buy your solution for my hospitals or my TPA and so on, information will be sent to APHP databases?
So actually, what we did is we have a cloud platform fully standardized towards the RGPD, the GDPR, and we will be connecting to any kind of healthcare facilities, and we are actually interoperable with the information system that wants to get the data into their own systems. So obviously, since the very singular relationship that we have with APHP, it will be the first use case for us, but we can connect to pretty much any kind of healthcare facilities. We took care for having a streamlined pipeline for the data that can be anonymized, and also in the right, let's say that international standards like FHIR, FHIR, those kind of things, so that we could really be connected to any kind of healthcare facilities. Can be French or international, for instance, Chinese. Okay.
Thank you, Mehdi. So in France, you are based in Paris Santé Campus. It's a good opportunity for you. You told me at lunch you were very happy about that. Remember, and abroad, when you go abroad, we are lucky because we can work with Orange, our champion for security communication, and we're very happy to French healthcare to have you. To have Orange in Vacom. So what is your way of thinking about how you can carry a lot of startup, very successful and potential successful startup, to carry them and to build something like a frame of security connectivity frame? What is your strategy on the my question is, I'm in South Africa, South America, and so on. I want to use some this kind of very clever solutions, very interesting solutions from France, but I need to have something like an integrator, not only integrator, technical integrator. Do you play this game?
Yeah, for sure, for sure. I think there's two sides around this question. There is of course, like I mentioned before, Orange is operating worldwide, and we are in 26 countries. So there is this I would say, sales channel that is good, that could be delivered quite easily. But there is also another side, and I've heard about FHIR or interoperability. We could also play a role in that process, because there is a lot of very good ideas. Quantic is one of them. Very smart people that are creating some very interesting solution, but very often they are in trouble to get integrated with hospital information system, because it's to be honest, it's very tricky. And this is where we can also play a role with the cloud solution that could be also delivered around the world, and help them, support them in that process. I think there is really some value over there. You cannot be focusing on the specialty you are delivering. I think what Quantic mentioned is very innovative. So they cannot be everywhere. So they need to focus on their business and rely maybe on Innovacon or Orange for some specific issue like integration, which is quite difficult, and you need to be a specialist for really having something interesting to deliver.
Thank you, Simon. In the world, what are the main regions you are interested in right now?
Okay, so at Innovacom, it's quite easy. We have a good presence in Canada. We won a regional project. So we are delivering our platform to every hospital in Quebec, so which is almost half of the Canada, for people who don't know. We are also serving some hospitals in the UK, NHS Trust, but also in Europe, French-speaking Europe, Switzerland, Belgium. We have a very interesting project in Finland, very innovative hospital, new built, and they are using actually one of our solutions every day to take vitals, and this is something interesting because they are really mobile oriented. This is not the case in Europe, where the mobile is not widely used inside the hospital, but over there, if you are not mobile, you don't have any place to play. And we are really exploring the Middle East region, and it seems that we could have a lot of attraction over there. So let's see what's happened next time.
Okay, I think that this region is very interesting. It's
definitely. Yeah.
I'm very impressed by the money put into the system here, not only the health system, but it's incredible, really. So we've got to organize ourselves in France to go to be more present in this part of the world, I think.
And they really consider digital as this is key for them. They really take that as a...
But the competitors are very strong, very American ones, and especially I thought the booth of American John Hopkins Hospital, a friend of mine, is in charge of international. We can make some partnership for Professor Antoine Celia, but also Mayo Clinic and so on. They are very present here. Robin, a few words. What is for you, in your experience, the most interesting country to observe how they get from low level of e-health to a good level of e-health?
So actually we could we could see that during the past 2 years. India is a good example. Before the pandemic, there was a few initiatives on telemedicine. However, they did a huge improvement where they built a national public telemedicine platform where everyone in the country can access that platform, and supported by national trainings and standard of good practices. So India was a very good success, and in France it was not a low level, but we saw a huge increase during this past 2 years, and maybe the two regions that increased a lot comparatively could be Southeast Asia, mostly mobile driven actually, and the Middle East, where there was a huge increase. And just to give a few last comment on the previous question, which actually triggered some ideas. We have actually in France a national pilot program for remote patient monitoring of diabetes, funded by the government since few years. So if UAE nationals or hospital director or company are interested to support this funding, we have the experience and we can share it as well.
Do you think they have got diabetes people here? I don't know. I'm not sure. I'm joking. A lot of course. Mehdi.
Yeah.
Yeah. I want to buy EcoPen. When it will be possible, and is it expensive? I'm sorry about this very trivial question.
No, this is one of the key aspects that we have been working on for the last few years. It will be around, let's say, 10 times cheaper than what you get on the markets, usually on average, for an alike quality. And this is something like one of the key advantages of EcoPen. And obviously, if here in the audience people want to know more about our technical characteristics and how we'll get to this price, we're open to discussion. We're expecting the CE mark in the next few months, hopefully in the markets in the next 3 months.
Okay, thank you. That's very clear. 10 times less expensive, you told us.
Around 10 times less expensive than the average on the markets, yeah.
And for the services, it's 80% of the scope you can use for the most important device, you told me.
Yeah, it's a screening tool that enables you, to do orientation diagnosis in a large amount of diseases. And let's say that this is by default, and on the top of that, we put AI systems where we can enhance some interpretation abilities for the end user, for the medical doctors or the paramedics. Yeah, definitely.
Okay, typically, what kind of client you want to address in the beginning of September, for instance? It's emergency services?
Yeah, let's say that if we go to our market access strategy, I won't go into detail, but let's say that basically hospitals are very important, healthcare facilities in general are very important targets for us. And in this, all the practitioners that make, let's say, a general use of medicine, like emergencies, anesthesiologists, people working in resuscitation rooms, pediatricians, and guys in internal medicine are really into our very first scope.
Okay, we've got 5 minutes to the end. I jot some words about the French Care Association on my workshop because I'm the pilot. That's very important for us in France that to spread our wings and to sell our solutions, our services. It's also a responsibility approach, and we've got to have a sustainable approach and to promote also to increase the level of skills for physicians and nurses and so on in the countries. So that's I think a big difference between our country and the other countries. That we want to spread our wings, of course, but we know that with our experience, it's not only my opinion, is that it could be sustainable because we want also to transfer, to give some skills and to transfer skills to people we work with. That's very important. That's I think a very big difference between the French approach and the other. Also, in our group, we are working on solution services with performance, but also how to link to the reimbursement schemes, policy of reimbursement in the country, and also non-profit organizations like Mutuelle, and we've got here in Dubai Yannick Luca from Fédération Nationale de Mutuelle Très Française, and that's in our group in French healthcare. We make the link between the solutions, services, ideas, innovation, and also how to implement with ethic, transfer of competence, and how to get into the scheme reimbursement. That's very important. So, Antoine, I will ask you to give maybe two or three words. It's freestyle as you want. Antoine, what 3 words you want to say to all people, and the replay will be very interesting for them.
Well, basically, I think what summarizes the exchanges today, I would say excellence, innovation, and success. And I hope a lot of collaboration will come out of this discussion. And again, Paris Santé Campus is very much open to welcome anyone who would like to visit and collaborate with the French healthcare system.
Okay, Dubai people bought their tickets, as they told me. Okay, thank you, thank you, Antoine. It was very, very clear.
Do we have time for one last question? Sorry.
Oh, another question. Okay, let's go. Noemi.
Yes, there is a question in the live chat. So the question is, how did the pandemic help e-health in general and your solution specifically to become more part of the mainstream care delivery? And what will be the which will be the enablers to sustain this move?
Allez, Simon. Okay. Simon, short answer, please.
Very good question. Very big question as well. I'm not sure to be able to answer that in 1 minute, but for sure, e-health has been driven by this pandemic because we understood when I say we, this is the healthcare organization in general that we've been late in this domain against other industries, and it has been like a real discovery for them. So I think now everyone knows, and they are investing a lot, and they really think that e-health solution can be really efficient and helpful for everyday care, and I think this will be sustainable in time, in the time. So I think for sure.
Okay, Robin.
I can add just one point for us, but I think it's the case for Quantic and all the guys here. For sure, remote access to healthcare information are now really critical. And as for us, obviously, we can also share remotely the data. I think Quantic can, and I think this is really the next move forwards for all the industry of med technology and for the healthcare usages. And besides, one point maybe more specific to Ecoburn is that there were a lot of publications those last few months, and especially one in the Lancet, where a panel of experts drew what should look like a healthcare facility, a primary healthcare facility especially. And there were this opinion that among several tools, critical tools, ultrasound handheld device should be one of them in the post-COVID world. So yeah, broadly, definitely COVID accelerated the move towards everything that we can do remotely.
Is that your last words, Mehdi, or do you want to say something more? Okay, it was your last words. Robin, your last words.
So I will go on the second part of the question. For me, would be a legal framework. Today, majority of the countries in the world lack a proper healthcare framework, and especially for digital health or telehealth framework. So we don't know who has the right to do what and with which consequences, and that can be a big problem. The second one is technical infrastructure, how to identify a patient digitally, how to identify a hospital and a doctor. The data sharing was already said, and I would add as well continuous medical and scientific research, because it's not because something is innovative in the medical field that it actually has a demonstrated scientific impact. So we need to continue this as well. Thank you.
Thank you, Robin. Alain?
Thank you.
So my last word. Okay. Actually, what I would say is, so our field is pretty difficult, you know. So we need to certify, we need to work together, and we need to work together again. I mean, if I would say one thing is we should try to work with startups, with big companies, to share data, to make new projects and try in the fields together. It's something that usually is not done, and I would say that we should start a little bit more.
Okay, I've got 4 last words. 2, choose friends, and thank you. Bye-bye.
Thank you.